Bonjour Joël.
Bonjour.
Bonjour Joël. Je te téléphone parce que je pense que ce serait bien si tu pouvais te rendre assez vite dans la salle parce que je ne suis pas sûr qu'ils aient les PowerPoint sur leur ordinateur, les quatre. Et en fait, il semble qu'on n'ait pas le share screen ici il n'est pas activé, donc tout doit être animé, semble-t-il, depuis Kigali.
D'accord.
Alors, si tu n'as, s'ils n'ont pas les quatre, je viens de les renvoyer, donc les quatre PowerPoint dans deux mails différents. Je t'ai mis en CC. Donc, si tu as une clé USB et que toi tu peux te connecter, tu peux peut-être faire tout ça, quoi. Merci.
La salle tout à l'heure,
Ouais.
dans l'avant, je vais y retourner.
Merci beaucoup. Allez,
Voilà, je t'en prie.
allez,
Voilà, à bientôt.
à bientôt. Bonjour Serge, tu m'entends?
Oui, bonjour Bruno, je t'entends très bien. Et toi, tu
Voilà.
m'entends?
Oui, je t'entends bien, très bien.
Ok.
Tu peux peut-être activer ta caméra pour que je vois ce que ça donne de ton côté. Ok, c'est bon. Alors, Serge, ils n'ont pas. Tu peux noter qu'en haut de ton Zoom, tu n'as pas la fonction de partage d'écran, en fait, hein, normalement. Donc, ça veut
Effectivement,
dire
je peux pas.
ils vont animer les DIA depuis Kigali.
Ah si, je peux partager en bas.
En bas, ah oui, toi tu peux. Ah
Bonjour.
oui.
Oui, vous pouvez partager votre écran depuis Zoom. Il n'y a pas de problème.
Ah, ok, très bien. Ça, c'est une bonne nouvelle. Ok, ça va. Alors, qui vient de nous dire bonjour? Excusez-moi, j'étais perdu.
C'est Thomas Vernier, pardon.
Ah,
J'étais en
très bien.
contact avec Bruno, justement.
Voilà, c'est bien, c'est moi. Ok, super. Donc, on peut partager l'écran. Ben, c'est bien. Donc, la première PowerPoint, ça va être Joël. Ok, puis ce sera, ça va. On va devoir faire circuler ce partage d'écran, mais on y arrivera. Ok,
Et
je vais
puis,
écrire
moi,
Joël.
moi, j'interviens à quelle position?
Tu parles en dernier, Serge. Tu parles
Ok,
après Matt.
ok, super.
Ok.
Car vous vouliez connecter votre salle plutôt que vous connecter sur votre ordinateur, c'est ça?
Oui, j'aimerais bien faire ça, mais alors je ne sais pas comment je dois faire ça. Euh, Attendez, je vais
Alors, je
faire ça
pense que dans la
ici.
salle, vous pouvez vous connecter avec l'ID et le password que je vous ai envoyé.
Ah voilà, je dois regarder ça. Je dois d'abord me. On va
Et après,
essayer.
je pense que si on vous accepte, ça devrait être bon.
Oui. Alors.
Je ne comprends pas ce qu'on fait. Qu'est-ce qu'on a fait?
Non, c'est pour moi, Serge. Moi, je
Ah,
vais
ok,
essayer de me connecter avec. Je suis dans une salle de vidéoconférence. Et donc,
d'accord.
je vais voir, parce que ce sera peut-être mieux pour. Voilà. Oui. Oui, yes, we can assign the room as this
Moi,
might
non,
work.
moi, je fais rien du tout, c'est juste partager mon écran, c'est tout, hein. On est en
Oui, oui,
contact
tu fais
avec
juste
la salle.
partage d'écran. Alors, je vais faire probablement un Zoom. Moi, je pense qu'il me faut un meeting number and meeting passcode.
Oui, c'est ce que je vous ai envoyé par email, justement.
Alors, meeting.
C'est le mail de 12h07.
Ah, de 12h07, ok. Ah oui, voilà. Donc, enter meeting. Ok, j'essaye. Deux, un. Alors, il y a un message qui apparaît ici à l'écran. Jonas, il y a un message qui dit: The host of this meeting does not have a conference room connector CRC license.
Ah, ok. Ouais, on a déjà eu ce problème-là avec les Zoom webinaires.
Mm.
Donc, je crois que ça fonctionne avec les meetings, mais webinaires, il y a toujours ce souci-là, ouais.
Ouais.
Ça arrive.
Euh, ok, ben alors on va faire une connexion à partir d'écran alors.
Mhm.
On ne peut pas
Je
avoir
pensais.
We cannot have the meeting room, so we will have to connect with your laptop online. Okay. You receive, Jonas, I think, send you also this morning the link. Do you need a connection to the electricity, or you
Maybe later, but we
Okay.
can share. Oh, no.
Mine is I can't share. I need it permanently. But we
Ridiculous, isn't it?
but the most important is you anyway.
Give you one plug on here's one. One plug in here. For these laptops. Can you not get a new battery? Might be worth
Within inside, I tried 2 3 years ago, and
it.
they were not responsive. I decided to.
Try Julien again.
Oh.
You never know. It's worth it.
Okay, so check
Hello,
here.
Bruno. I am in.
Voilà, Jean-Paul, bonjour.
Hello.
Très bien. Donc, a priori, moi, je ne parle pas, hein, so I don't speak normally, but do you have it? Yes. Okay, Matt is trying to connect.
Can I share my screen? Will I be able to share my screen from here?
Look at the bottom of your screen. There is the share function. Do you
Okay.
see? Okay.
Yes,
So
that's
it
perfect.
should work. I could do them actually. I have all the slides. So maybe I could centralize.
Although I quite like to,
You like to move yourself?
because I usually have animation, you see.
Okay. So
So
Matt is there now. So if you want, you can share, each of you can share your screen, then we have time. So that's maybe the best model.
let me just find my presentation.
Yeah.
So what I have.
I will have to put myself on mute, I guess. Huh?
Hello, Matt.
Hello Matt,
Hey,
C'est Serge, hein? Voilà. Bonjour, voilà. Il est là.
bonjour,
Serge,
bonjour.
ça va? Comment tu vas?
Ça va très bien, merci. And you?
Pas mal, merci.
A rush, but it's okay. Okay.
I'm just checking my own presentation to make sure I know.
Mhm.
But we're on your microphone then at the moment.
Yes.
Can I start to share my screen?
You can
I
try.
I can try,
Yes.
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 It's okay?
I don't know how it is in Kigali. Here in Geneva, we see two slides, the one and the next one.
Okay.
Kigali, we see the 2 screens as well.
Okay. So you have to.
It's okay now?
Yes, it's okay. Is it okay in Kigali on the main screen?
Yeah, now it's fine. Now it's fine.
Okay.
Okay. You see only
Good.
one slide now.
Yes, now we see only the cover.
Okay. Wonderful.
So I don't know if the translator are with us already. So Serge will speak in French. Jean-Paul, I think, will speak in French. Matt will speak in English. So it will be a mix. Yes, definitely.
Sorry.
No, it's okay. I can close this.
Jean-Paul, you can try now if you want.
Yes, let me try. First, remove all of these.
Jean-Paul, we see the slides at the bottom, the next ones. So you have probably to find how to put in presenters mode.
Alors, so let me try again.
Swap
Stop
display.
share.
Hmm.
Jean-Paul, va, repartage et regarde au-dessus. Tu vas voir, on a écrit swap display. Tu cliques dessus.
On a
Repartage,
écrit quoi?
swap display. Repartage, je vais te montrer. Repartage son écran.
Ok.
Voilà, mes diaporamas. Ok, regarde au-dessus. En haut à gauche, on a écrit swap displays. Ok, formidable. C'est bon.
C'est bon.
It's okay now
Merci.
for Jean-Paul.
We try with Matt now, okay?
Yes.
So I see that the room is still empty. So it's okay. It's working well, Matt.
I just how long do we have?
Can take your time. And I will tell you if you are too long. And
15 minutes, something, 10,
yeah,
15.
it's 15. I think I will have to do some indeed the time keeping. Let me check the timing indeed.
And the ordering, and this is terrible. I can't remember anything. Who goes first?
So the first is Joël, then it's Jean-Paul, then it's Matt, and then it's Serge. We have 90 minutes in total, but we are already hitting this time as people are late. So if we do 15, 16, well, if we do each 15 minutes, we would still have 20 minutes of discussion. I may be the timekeeper for this session. I think that's maybe my role. And if I feel that you are too long, I will interrupt some of you. I will be very impolite, but
That's good. That's good chairmanship. But don't say finish now. Say you have 1 minute or something. 2 minutes.
Serge, tu m'appelles sur WhatsApp?
Bon. Maintenant, je... C'est bien, Serge. Je vois que tu m'attrapes maintenant.
Il n'y a personne.
Ok.
Qu'est-ce que vous... Il faut sortir prendre les gens.
Ah, mais Serge, il n'est pas à Kigali, hein. Il est
Ah
où?
bon, qui est là?
Joël est à
Il est
Kigali.
Non, non,
Joël
Joël.
est in Kigali.
Joël,
Joël.
Et il est
Bon,
où
Serge,
maintenant?
ils sont peut-être en train de manger ou je sais pas quoi. Merci, Serge, hein.
de rien.
Tu, tu vois le coup que je t'ai fait avec la cravate, tu me l'as fait payer. Tu aurais pu le faire en plénière, hein, en public.
Non, j'ai oublié de protéger.
Ou alors, j'ai un message de Jean-François Carremel.
Bruno, on prend contact un peu avec Joël pour voir,
Oui,
peut-être au
mais
moins déjà pour me donner des nouvelles.
Là,
ouais,
ça marche.
je peux l'appeler. Mais
Peut-être qu'il a oublié, hein.
non, 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 il est au courant, il est au courant. Mais ce qui m'étonne, c'est qu'il ne relève pas mes messages.
On peut pas oublier, non? C'est ça, c'est interdit.
Avec les responsabilités, ça devient compliqué.
Voilà. Joël était dans la mauvaise salle, donc il arrive. Bon, les gens sont encore en train de manger, donc on va commencer avec retard. C'est, c'est un peu le problème, mais on peut pas. J'espère que vous avez un peu de travail en parallèle.
No, I think it was good. We should take some of the discussions into our own meeting, actually.
Do we have other participants online?
I don't think so, because the online participation for the next days is only for those with who paid the fee. So voilà, je vois qu'il y a quelqu'un dans la salle, c'est peut-être Joël. Je ne sais pas s'ils nous entendent.
No.
Là, ah oui, voilà, nous on voit de très
There's an
loin.
audio guy in the corner, isn't there? That he's going to speak with him. Is that Joel? It's Joel. no?
Peut-être, peut-être. In the room in Kigali, do you hear us when we speak? Can you confirm that you?
maybe.
Yes, we hear you. We hear you.
Okay, very good. Okay,
Brother, this
so
is Juliet. How are you?
oh,
Julia,
how are you, Julia? Good to hear you.
Good.
How's it going there?
So I'm with Matt, huh?
Oops.
Oops. Yes. Where is she, Juliette, now?
Bruno, tu nous entends?
Oui.
On t'entend
Joël,
très bien. On vous entend super bien.
on
Donc,
t'entend super bien même.
quand
Donc, je
vous voulez
disais à
commencer,
Juliette si elle pouvait être modératrice. Bon, mais elle a un problème avec la traduction.
ouais.
Donc, elle dit d'attendre juste un peu. Donc, pour qu'elle voit si elle va trouver quelqu'un pour nous aider.
Mhm. Mais sinon, est-ce que les gens ont terminé leur repas? Est-ce que c'est... On voit que vous n'êtes pas beaucoup, pas nombreux dans la salle.
Bon, on n'est pas très, très nombreux. Un peu moins de 10.
Ok. Est-ce que les gens pourraient peut-être se mettre un peu plus ensemble dans l'axe de la caméra, comme ça? Pour l'instant, nous, on voit seulement un monsieur. Donc, si vous pouviez être peut-être sur les deux tables au milieu, comme ça, on a un peu plus l'impression d'avoir une vraie
Ici.
audience.
D'accord. Donc,
Merci à vous tous qui vous déplacez. Et on verra les mains qui se lèvent comme ça, si le cas échéant.
d'accord. No, here. The camera is here. And you come to be in front of a camera.
And we had the same topic yesterday, so many people think that it's the same session. Forgot to remind that it was the same one. But yesterday it was.
OK. En fait, comme on n'est pas nombreux, do you speak French, English? Voilà. So we want people to go here to be in front of the camera because we are not. Yes, normally, yes. Yes, the police learning, yes. Hmm? No, we want people to go there. We are not many for people online. Voilà. It's here. It's to be in front of a camera so people online can interact. Is it okay? Well, if there is not someone,
You start, then we will hand over.
I will be a presenter and also. Let me see.
But I think we have to start.
Okay.
We have to start.
Okay, can we display? We'll start.
Donc, Joël, yes, we confirm, we propose that you start.
Okay. So do you want to make the introduction?
No, it's okay, Joël. I think we have lost already some time, so I propose that we go ahead. So, hi, everyone. We are happy to be with you. Initially, the plan was that we travel to Kigali, but we could not make it. We had a similar session yesterday, but this one is different because we will mainly hear speakers presenting their work. So we will have Joël in the room, Jean-Paul, who could not make it, and who will be from Cotonou, Matthew Jowett, who will speak from Geneva next to me, and then Serge Mayaka from Abidjan. And yes, we really want to reflect on policy learning for health financing, and we will share different experiences and different lessons. There is no remote audience, so it's really the idea that you organize the time according to your priorities in Kigali. So Joël, you take the lead and present, and then chair if you need to chair.
Okay, thank you
Okay.
very much. Bruno. I plan to speak in French, but I can try in English. Okay, so thank you very much for coming. Is it okay? En français, ça peut aller. D'accord. Donc, bienvenue à tout le monde et merci d'être là à notre session organisée. Donc, nous allons nous entretenir aujourd'hui sur l'apprentissage des politiques. Et cette présentation que je vais faire, c'est un guide d'introduction. Et nous allons voir spécifiquement comment l'apprentissage des politiques donc, peut être exploité donc, dans l'élaboration des politiques et également pour réduire la fragmentation du système de santé. Donc, en prenant comme illustration donc, l'achat stratégique des soins de santé au Burkina Faso. Slide. Donc, on sait tous que les réformes sont importantes donc, pour soutenir les pays dans leur marche vers la couverture sanitaire universelle. Mais qui parle de réforme parle aussi d'incertitude parce que nous savons que les systèmes de santé sont complexes et quand on met en œuvre une réforme avec une théorie de changement, donc bien identifiée, ce n'est pas dans toutes les situations où ce qu'on a planifié donc, donne les résultats qu'on a espérés. Et ce qui marche dans un contexte ne marche pas nécessairement dans un autre contexte. Et il est très, très important d'être proactif et de s'adapter de façon continuelle. Et comment s'adapter? Donc, nous pensons que l'apprentissage est très important. Et comment nous pouvons définir l'apprentissage? Donc, on peut dire que c'est une mise à jour des connaissances, des pensées et des actions, donc sur la base d'expériences vécues ou bien sur la base de ce qu'on a observé. Et cet apprentissage peut se faire aussi à partir d'une certaine analyse des données ou à travers des interactions sociales. Et l'apprentissage des politiques, donc c'est le processus d'apprentissage donc appliqué donc au processus d'élaboration des politiques. Et on peut par exemple se mettre dans une dynamique d'apprentissage pour résoudre des problèmes de santé et des problèmes donc, au niveau du système de santé. Donc, l'apprentissage peut également concerner les différentes solutions donc, pour résoudre ces problèmes. L'apprentissage peut concerner le processus même de mise en œuvre de la politique, comme on peut également apprendre des résultats des différentes politiques. Maintenant, la présentation d'aujourd'hui, comme je le disais en introduction, donc c'est de voir comment l'apprentissage des politiques peut contribuer au progrès vers la couverture sanitaire universelle. Donc, en prenant le cas particulier du Burkina, où nous allons appliquer donc, un cadre spécifique donc, à l'achat stratégique. Maintenant, c'est quoi la fragmentation? Donc, je pense qu'une clarification conceptuelle est nécessaire. Donc, généralement, dans les pays, on a plusieurs dispositifs de financement donc, qui sont juxtaposés. Donc, avec un problème de coordination, un manque de complémentarité ou de cohérence entre ces politiques, ou bien un manque de synergie. Donc, je dirais que le problème n'est pas forcément le nombre en soi, mais c'est parce que très souvent, ces politiques ne se parlent pas entre elles. Et cela est source d'inefficience et peut même entretenir des iniquités dans le système de santé, donc ce qui va entraver les progrès vers la couverture sanitaire universelle. Maintenant, pourquoi nous avons des dispositifs de financement fragmentés? C'est très souvent lié au fait qu'on a plusieurs acteurs au niveau du système de santé, donc avec des logiques et des idéologies différentes. Donc, on a parfois des promoteurs de certaines politiques et certaines de ces personnes ont parfois donc, des positions assez dogmatiques. Donc, on n'accepte pas toujours le dialogue ou les opinions des autres personnes parce qu'on croit que la solution donc, qu'on met en œuvre ou dont on fait la promotion est la meilleure des solutions. Voilà. Et aussi, très souvent, donc les évidences scientifiques ne sont pas toujours concluantes. On va voir parfois pour une même politique, une étude qui va dire que ça marche, une autre va dire que ça ne marche pas. Donc, très souvent, le décideur politique ne sait pas où aller, on ne sait pas exactement qu'est-ce qui marche et qu'est-ce qui ne marche pas. Maintenant, qu'est-ce qu'il faut faire face à la fragmentation? Donc, nous pensons qu'il faut revoir la manière dont les politiques sont élaborées. Et il est également important donc, de combiner différentes perspectives, de combiner différents mécanismes, donc pour voir justement comment trouver les différentes complémentarités et synergies entre les politiques. Et pour cela, il est important de communiquer donc les différents acteurs de mise en œuvre des politiques où les acteurs qui font la promotion des différentes politiques communiquent entre eux, qu'ils apprennent à collaborer, à partager l'information, donc à développer un certain dialogue politique. Donc, en d'autres termes, nous pensons qu'il faut promouvoir l'apprentissage des politiques. Donc, ici, nous allons appliquer un cadre qui est issu des sciences politiques. Donc, c'est le cadre de Dunlop et Radaili. Donc, ils ont élaboré ce cadre donc, en 2013. Et sur ce cadre, on a deux grandes variables qu'il faut regarder. Donc, c'est le degré de difficulté donc des problèmes, donc le problème tractability. Donc, on peut être dans une situation où on a des problèmes qui sont difficiles à résoudre, comme il y a des problèmes qui sont relativement faciles où on a déjà des solutions qui sont là qu'il faut juste adapter. Et l'autre type de variable que ces deux auteurs proposent de regarder, donc c'est ce qu'ils ont appelé la certification donc des acteurs. Donc, qu'est-ce qu'ils entendent par certification? C'est la légitimité donc, que des acteurs peuvent avoir, soit en termes de connaissances ou en termes de leur position donc, dans l'écosystème. Donc, ça peut être au niveau d'un ministère ou dans une situation donnée. Donc, en fonction de cela, en croisant ces deux variables, donc si, par exemple, on est dans la situation d'un problème qui est difficile à résoudre, et si les acteurs qui sont autour donc, de la politique, il y a une certaine hiérarchie donc, entre les acteurs, donc ils proposent de faire ce qu'ils appellent l'apprentissage épistémique. Donc, on va voir tout à l'heure donc qu'est-ce que cette notion recouvre. Voilà. Mais c'est ça qui est à gauche. L'apprentissage épistémique, si vous voulez, c'est l'apprentissage à travers les experts, les académiques, les chercheurs. Donc, c'est pour dire qu'il y a une certaine hiérarchie des connaissances où on a un sachant et des gens qui apprennent. Voilà. Donc, quand le problème est difficile, donc, ils pensent qu'il faut recourir à ce genre d'acteurs pour apprendre. Maintenant, on peut se retrouver dans la situation où on a un problème qui est assez difficile à résoudre, donc la politique veut chercher à résoudre. Mais ici, il n'y a pas une hiérarchie des acteurs donc en termes de connaissances. Donc, il propose en ce moment, les deux auteurs, de se mettre dans une dynamique d'apprentissage réflexif. Maintenant, il y a l'autre situation où En fait, le problème est là, on a des solutions, plus ou moins, donc qui sont déjà disponibles. On sait à peu près donc, ce qu'il faut faire. Donc, dans cette situation, s'il y a une certaine hiérarchie des acteurs liés, par exemple, à leur position et autres, donc, il propose de faire ce qu'on appelle l'apprentissage à travers les processus hiérarchiques. Et à contrario, s'il n'y a pas une certaine hiérarchie entre les acteurs, donc pour mettre en œuvre la politique, donc il propose que les acteurs soient dans une dynamique de négociation. Voilà, donc c'est ce cadre en réalité qu'on a utilisé et nous pensons que l'achat stratégique, donc le processus d'achat stratégique, donc c'est une belle opportunité pour appliquer ce cadre, donc parce que c'est un concept donc, qui est relativement nouveau, donc tout le monde en parle, mais ce n'est pas évident que tout le monde a la même compréhension donc, de ce que c'est que l'achat stratégique. Donc en termes de méthodologie, donc, nous avons utilisé une étude de cas donc, avec une analyse qualitative des données. Donc, le cas ici qu'on a utilisé, c'est les actions mises en œuvre par le ministère de la Santé du Burkina Faso, donc pour traduire l'achat stratégique en politique et pratique. Et sur ce plan, nous nous sommes focalisés spécifiquement donc, sur deux actions. Donc, la première, c'est une tentative de couplage entre deux dispositifs de financement. Donc, le financement basé sur la performance et la politique de gratuité des soins pour les femmes et les enfants de moins de 5 ans. Donc, le financement basé sur la performance a été mis en œuvre entre 2018 et 2023 avec une prolongation d'une année, donc 2024. Et la politique de gratuité est mise en œuvre depuis 2016 et elle se poursuit. Mais la tentative de couplage qu'on va considérer, c'est entre la période 2016 et 2019. Voilà. Et on va voir que du fait de difficultés donc, que les acteurs politiques donc, ont eu, donc ils ont fait recours donc, à Spark. En fait, Spark, c'est le Centre des ressources africains pour les achats stratégiques, donc, qui a été mis en œuvre par l'ONG internationale Result for Development et AMREF, L for Africa, a pris le relais par la suite. Donc, c'est une structure qui a été mise en œuvre pour soutenir les pays dans leur dynamique d'achat stratégique. Donc, du fait des difficultés qui étaient éprouvées, donc, le ministère de la Santé a recouru donc, à Spark donc, pour avoir son soutien donc, pour la mise en œuvre de l'achat stratégique. Donc, ce sont ces deux actions que nous allons considérer. Et nous allons appliquer le cadre de Dunlop et Radaili que je viens de présenter tout de suite. Donc, pour essayer de voir les types d'apprentissage qui ont émergé ou n'ont pas émergé. Donc, qu'est-ce qui a facilité ou entravé leur apprentissage et qu'est-ce que cela a donné en termes de résultats politiques. Donc, les données ont été collectées à travers une revue documentaire et aussi des interviews donc, approfondies donc, avec des acteurs individuels. Donc, au tableau, on a les différents types de documents donc, qui ont été exploités. Et on a interrogé 21 donc, informateurs clés, dont 18 acteurs nationaux et 3 experts internationaux. Donc, au cours de la collecte des données, donc, on a également pris des notes sous forme de mémos, donc des mémos réflexifs et analytiques, donc au cours ou après les interviews. Donc, les données ont été analysées de façon manuelle en utilisant une analyse de contenu donc, pour identifier les récurrences donc, qui ressortaient le plus souvent. Donc, qu'est-ce qu'on peut observer en termes de résultats? Donc, on a identifié un certain nombre de difficultés donc, dans les mécanismes d'apprentissage. Donc, on a voulu coupler donc, la gratuité avec le financement basé sur la performance. Et de prime abord, donc, on a pensé à tort que ça allait être facile. Donc, parce qu'il faut dire que dans le contexte du Burkina, il y a beaucoup d'évidences scientifiques donc, qui ont été écrites, donc surtout en matière de financement de la santé. Donc, notamment, il y a les écrits sur la politique de gratuité, sur les soins obstétricaux et néonatals d'urgence, sur les mutuelles de santé. Donc, il y a beaucoup d'écrits scientifiques. Mais quand il s'est agi de l'achat stratégique, donc même si on mettait déjà en œuvre le financement basé sur la performance, donc on s'est rendu compte que l'expertise n'était pas vraiment développée. Parce que c'est un concept qui était relativement nouveau au Burkina. Donc ici, nous sommes dans les années 2018, hein. Donc on était dans une situation où le concept est relativement nouveau au Burkina et même en Afrique, et on n'avait pas vraiment des experts qui s'y connaissaient. Donc pour essayer de guider les différents acteurs donc dans leur volonté donc de coupler la gratuité et le financement basé sur la performance sous le label justement de l'achat stratégique. Et beaucoup d'acteurs ne faisaient pas de différence entre le financement basé sur la performance et l'achat stratégique. Donc, cela a fait qu'il y a eu des difficultés dans le couplage parce qu'il n'y avait pas assez donc, de facilité donc, en termes d'apprentissage épistémique. Donc, si on passe à l'apprentissage par la hiérarchie, donc ce mode d'apprentissage était également absent, donc parce que les supérieurs hiérarchiques n'étaient pas capables de donner des directives claires sur ce qu'il fallait faire. Donc il faut dire que coupler les deux politiques, donc c'est vraiment quelque chose de nouveau. Donc les gens savaient qu'il y a eu une tentative au Burundi. Ils avaient même entrepris de faire un voyage d'études, mais ce voyage d'études n'a pas eu lieu. Donc on peut dire que les gens en tout cas, et naviguaient un peu à vue et les autorités donc n'avaient pas de guidance claire donc, à donner aux différents acteurs. Donc les techniciens étaient obligés de se débrouiller eux-mêmes donc, pour trouver les différentes solutions. Et il faut également dire qu'il y a eu un peu d'instabilité politique donc, au Burkina. Parce que vous savez, entre 2011 et 2018, on a eu 5 ministres de la Santé avec 5 secrétaires généraux du ministère. Donc, ça faisait que tous ces acteurs qui passaient n'avaient pas le temps de vraiment s'approprier et de savoir ce qu'il y avait en termes de développement de politique. Et il faut dire également qu'entre les deux politiques, donc la gratuité avait un meilleur, disons, ancrage institutionnel, donc parce que c'était une décision politique, donc par un décret présidentiel. Parce qu'en termes de contexte, la gratuité a été une promesse électorale donc en 2015, et donc par la suite, donc la gratuité était mise en œuvre et avait une plus grande attention des acteurs politiques, contrairement au financement basé sur les résultats, donc qui est resté une politique pilote, donc mise en œuvre par la Banque mondiale. Donc en termes d'apprentissage par la négociation, il faut dire que cela aussi a péché à cause d'intérêts partisans. Donc on sait qu'il y avait des gens qui avaient des intérêts particuliers dans le financement basé sur la performance, d'autres avaient des intérêts dans la gratuité. Donc, et ces deux n'ont pas pu vraiment concilier leur point de vue et se mettre d'accord. Donc, il y avait beaucoup de positions dogmatiques et il y avait également un déséquilibre de pouvoir donc, par rapport à ce que j'expliquais, si bien que la participation aux différentes discussions n'était pas toujours donc, effective. Il faut dire que les acteurs qui faisaient la promotion de la gratuité étaient en position de force donc par rapport aux acteurs qui faisaient la promotion du financement basé sur la performance. Et la gratuité était financée à 100% sur le budget de l'État. Et comme je le disais, le financement basé sur la performance était financé par la Banque mondiale, donc à titre d'expérience pilote dans quelques districts. Voilà. Et il n'y avait pas de facilitateur expérimenté donc, et crédible pour permettre de transcender donc, toutes ces différences et ces divergences de point de vue entre les différents acteurs. Enfin, pour l'apprentissage réflexif, donc il faut dire que c'était le type d'apprentissage qui était assez présent. Donc pourquoi? Parce que lors des interactions qu'il y a eu entre les promoteurs du financement basé sur la performance et les promoteurs de la gratuité, Donc, ils ont pu quand même identifier des points de convergence et de divergence entre les deux politiques. Et ils ont même identifié ce fallait faire pour assurer le couplage de ces deux politiques. Mais il faut dire que cela n'est pas arrivé à terme. Cela n'est pas arrivé à terme parce que, et je l'avais expliqué tout à l'heure en lien avec l'apprentissage, donc par la négociation. Donc les gens avaient vraiment des positions très arrêtées, des idées préconçues, et personne ne voulait vraiment changer donc sa perspective et il n'y avait pas assez de facilitation. Si bien que les points qui avaient été identifiés au départ pour faciliter le couplage entre les deux politiques n'a pas vraiment pu avoir lieu. Donc, c'est face à toutes ces difficultés que le ministère a fait appel à Spark, donc le Centre de ressources africain en matière d'achat stratégique, donc en février 2020. Et il faut dire que quand Spark est venu, les choses ont bougé un peu. Donc, les choses ont bougé. Bon, parce que l'apprentissage épistémique qui était absent, donc on l'a eu avec Spark, qui est venu avec ce qu'ils ont appelé cette approche fonctionnelle de l'achat stratégique. Et ça a permis, en tout cas aux différents acteurs, d'avoir une meilleure compréhension et connaissance de ce que c'est que l'achat stratégique. Donc, en tout cas, cet apprentissage épistémique a été présent. Donc, il faut dire aussi que Spark a joué un rôle de facilitation. Ils ont essayé de mettre les différents acteurs ensemble pour discuter. Et cela a permis encore aux différents acteurs de mieux comprendre parce qu'il y a des exemples concrets qui ont été donnés de comment l'achat stratégique pouvait être appliqué de façon concrète. Et il faut dire aussi que la Banque mondiale finançait le financement basé sur la performance. Et je disais que le projet, c'était entre 2016 et 2023. Donc, jusqu'en 2020, après 2 ans, rien ne bougeait. Donc, on a d'abord fait une première restructuration et on s'est rendu compte que rien ne bougeait encore. Donc, les gens ont compris qu'ils risquaient de perdre l'argent de la Banque mondiale. Donc, ça a été en tout cas un motif qui a commencé à faire bouger les choses, dont les acteurs étaient obligés de se mettre d'accord pour élaborer une feuille de route et commencer à mettre progressivement l'achat stratégique. Mais il faut dire que le consensus a été d'appliquer l'achat stratégique maintenant à la politique de gratuité. Donc, ça signifie que de façon concrète, on a abandonné l'idée de coupler deux politiques, donc le financement basé sur la performance et la gratuité, mais on a essayé de prendre des approches de l'achat stratégique qu'on retrouvait dans le financement basé sur la performance, pour essayer de les appliquer maintenant à la politique de gratuité des soins. Donc, c'est le compromis auquel les gens sont arrivés et c'est cela qui a vraiment fait bouger les choses. Mais quoi qu'on dise, il y avait toujours de petites difficultés qui existaient. Donc, parce que les gens disaient que c'était toujours le financement basé sur la performance qu'on voulait mettre en changeant juste la forme et la manière. Donc, cela a fait que le processus n'est pas totalement allé jusqu'au bout. Donc, qu'est-ce qu'on peut apprendre de tout ceci? Donc, nous pouvons dire que l'apprentissage est pluriel et il faut tout faire pour tirer profit de tous les différents types d'apprentissage. Donc, ces apprentissages sont pluriels et elles doivent coexister et il faut vraiment les reconnaître et tout faire pour les exploiter. Mais on constate à travers cela que différents types d'apprentissage sont parfois négligés dans les efforts des pays pour progresser vers la couverture sanitaire universelle. Mais c'est important d'exploiter ces différents types d'apprentissage, comme je le disais, parce que de nos jours, on a assez d'experts, par exemple en matière d'achat stratégique. Donc, c'est très important d'exploiter cette situation, même si le concept reste toujours à creuser et à élucider. Donc, on a quand même déjà de l'expertise donc pour exploiter cet apprentissage épistémique. Voilà. Donc l'apprentissage par les processus hiérarchiques est important et utile donc pour guider les différents acteurs et avancer, mais on constate que cela requiert un gros leadership. Donc cela est très important et très souvent aussi les décideurs politiques ont besoin d'un renforcement de leurs capacités donc pour que cet apprentissage puisse être effectif. Nous pensons également que l'apprentissage par la négociation mérite donc une attention assez spéciale parce qu'on sait que dans les discussions et dans les processus d'élaboration des politiques, donc c'est parfois tendu, les gens ont des intérêts donc qui sont parfois divergents. Donc pour avoir un processus souple et fluide, donc l'apprentissage par la négociation peut aider à faire avancer les choses. Et l'apprentissage par la réflexion donc, est également important parce que dans ce type d'apprentissage, donc, tous les types de connaissances sont valorisés. Et comme on fait parfois face à une complexité des différents processus, donc nous pensons que ce type d'apprentissage donc, peut être très utile. Maintenant, qu'est-ce qui est important à considérer pour que ces différents types d'apprentissage soient effectifs? Donc, nous pensons qu'il faut beaucoup miser sur les techniques de facilitation. Voilà. Et ces techniques de facilitation doivent vraiment être ancrées et adaptées au contexte des différents pays pour qu'ils puissent vraiment se les approprier donc, et développer leur propre agenda et leur propre mécanisme d'apprentissage. Voilà. Et ici, donc, c'est juste un exemple donc, qu'on peut prendre. Par exemple, qu'est-ce qu'un facilitateur peut, par exemple, faire donc, s'il fait face, par exemple, à des acteurs, des politiques donc, qui n'arrivent pas à s'entendre, par exemple, un bon facilitateur donc, peut, par exemple, identifier donc, quel type de désaccord donc, peut, par exemple, nécessiter qu'on fasse recours, par exemple, à de l'apprentissage hiérarchique. Donc, ça, c'est vraiment lié à la qualité donc, du facilitateur. Le bon facilitateur saura également quel type de problème peut être résolu donc à travers donc, les données probantes scientifiques ou les experts d'opinion. Donc, à ce moment, il va essayer d'activer l'apprentissage épistémique. Le bon facilitateur peut également, face à certains désaccords, donc savoir que ce type de désaccord, on doit en tout cas laisser les acteurs réfléchir davantage et creuser donc pour voir qu'est-ce qui peut être fait. Mais également, le bon facilitateur, c'est celui qui sait négocier et qui sait également donc faire en sorte que les différents acteurs qui même parfois peuvent ne pas se parler, donc vont être sur la même table et accepter différents compromis. Donc, je vous remercie donc pour votre attention.
Thank you, Joël. I propose that we go on straight with the next speaker. So Jean-Paul, can you open your slide? Jean-Paul, I propose that we change a little bit the flow because we are running out of time. So for the moment, we see your Outlook or your Gmail, Jean-Paul. So can you put your PowerPoint on the screen? And Jean-Paul, we don't see your slides. Huh? Yes, and I propose, Jean-Paul, that you really stick to 10 minutes. So, and maybe, Jean-Paul, what is the most important maybe is that because you were involved in this policy process in Burkina Faso yourself, because actually you were the Spark facilitator, if I'm right, maybe if you can focus on a few messages which complement what Joël just presented. Jean-Paul, we don't see your slides. Are you with us, Jean-Paul? You are on mute.
Can you see my slide? No?
Not yet. We don't see your slides, Jean-Paul.
Will come. Here we go.
Okay, man,
Can
put
you
on.
see?
Yes. So Jean-Paul, try to be very effective. Can you, maybe you will not be able to cover all your slides. Sorry for that. But could you
problem.
reflect a little bit on what Joel just said and share maybe some key messages from the Spark experience? Over. Go ahead.
Thank you very much. So the driving question is really how to assist countries on the strategic health purchasing agenda. So really building on what Joel just said. I had the honor, so as Bruno said, to contribute to participate in this country support, and I use the cold learning cycle to reflect on my own experience in this whole process, and also doing some document review and share what I have learned, and hope this can help a bit to advance the learning about how to support countries about this complex process. So you know all the three main functions of the WHO approach to health financing. We focus on the last one, that is purchasing of services. And when it's come to purchasing, WHO define purchasing, say that purchasing is considered strategic when the allocation of resources are linked, at least in part, to information about the performance of providers and the health needs of the population they serve, with the aim of achieving efficiency gains, increasing the equitable distribution of resources, and managing expenditure growth. So Spark came with the idea to connect, contact, and connect again, meaning through coaching and mentoring, provide a pool of reference experts, match them with country needs, and ensure that there is an effective knowledge management and peer learning to support countries. So from the country need expressed, like it was the case in Burkina, then consultations and collaboration with stakeholders are put in place. A co-creation process is set up, and then there is a knowledge that emerged and brought to ensure that it gets to where it must be for the need to be addressed. So here come what Spark called the health system change process. So the Spark health system change process, from the challenge at the left to the stronger health system capacity and outcome at the right. You have so a process that aims at going deep to understand the problem, introduce evidence, select solutions, design, implement, evaluate, and adapt. Quite classical way to view a problem-solving model. Nothing very special. And in Benin and Burkina Faso, overall, what we did engaged some form of knowledge generation, learning, capacity building, and in-country technical assistance and policy process facilitation and support. So online, you will find many knowledge generation outputs in Benin, but also in Burkina Faso. And some results in Benin include, for instance, in-country networking and silos removing dynamics to address what Joel said that is critical to note about health financing scheme. There are so many interests and sometimes divergent interests of people that make them in silos, but also ideologies about what should work or not, or what should be there or not. So without going beyond those silos, it is hard to think about some coherent approach. So with that background about Spark, we came especially to Burkina Faso with the need to advance adoption and implementation of strategic health purchasing, with that request coming from the Minister of Health. And when we came first with the idea of understanding what was their needs, understanding the interest issues, trying to advance our knowledge about what people have to gain or to lose. We move from performance-based financing to embrace strategic health purchasing, and there were so many interests at stake. And from that perspective, we we also assess the practice. We try to identify a tool to assess the practices in terms of health purchasing that may not add straight to the cleavages, but that will facilitate the convergence of ideas. So we map progress in strategic purchasing in healthcare and also perform the evaluation of what we call the purchasing practices within a specific scheme that was the gratuity scheme. And from there, we try to, it was possible for us to like locate where the country was in its journey toward more strategic purchasing. And we were capable of saying, look, this is where we are now. It is possible that we move a little bit higher. And that was possible with that form of assessment to formulate a new vision that can put everybody together. And from there, we drew up and strengthened a plan that not only aimed at addressing weaknesses in the schemes that we use as a gate, as an entry point, but also that can open windows to systemic reforms. And then it came now to the stage where we have to support the to support, I will say, the implementation of the plan and the necessary reforms for the strategy purchasing to find strong roots into the system, and had at that moment also to deal as Joel said before, with the political turnover and challenges. At least we managed to reach a higher level of consensus to develop a roadmap to advance strategic purchasing in a World Bank project. We managed to develop an operational procedures with the identification of actors and role, at least start to set up some institutional arrangements and create a platform for continuing this conversation. So the main lessons we learned from a critical analysis of our failures and some form of success, I will say, is first, we have 50 shades in between what we can call fully passive purchasing practices and fully strategic purchasing practices. It is not a black and white story. There is so many shades in between. And if we open the conversation by empowering countries to locate themselves somewhere on this journey, it doesn't matter if it is fully accurate or not, but what matters is that people in the room can find themselves somewhere in that journey. And once they can locate themselves, it becomes easier to think about how to make any form of progress. The second learning is that it is a complex process, but it should look familiar. Health system strengthening, strategic health purchasing comes as a new concept, but when put into country, it must look familiar. You may be aware about these principles called the Maya principles in the design industry, and how from iPod to iPhones, there is this similarity, this familiarity that has been created and maintained. So I strongly believe from this experience that if the way we portray and design new health financing mechanisms, you can try to manage to make it look familiar, even if it is much more advanced and complex, we will gain so much in faster adoption and much more appropriation. The third learning is really about the power of facilitation. And I have learned that I have to better master three arts, I will say. The first one is the art of being neutral, the art of listening to the system, the art of being knowledgeable, but without always portraying myself as expert, because there are so many dimensions of system that we will never be expert about, but we still need insight from those dimensions to be capable of advancing our agenda as a facilitator. Then evidence and analysis are critical capacities for strategy. Have nothing to teach nobody here about the fact that no evidence, no information, no strategy. But evidence is not enough. We need analysis, capacities to make the evidence speak to each other and and facilitate the emergence of new way of looking at things that can facilitate the people to talk to each other. I will conclude by saying that through this process, I have learned that a multi-level macro, meso, and micro continuous learning is critical for strategy purchasing to move on. Learnings bring light on problems, bring light on solutions as well. Learnings allow those better allocation of resources, better design of programs. Beyond policies, design of programs require so much more specific attention. Then better programs enhance adoption, but also enhance self-efficacy of implementers and give chance for better delivery. And greater positive user experience at the end of the increase the capacity to mobilize more resources. And this creates the beginning of what we call the vortex of resource mobilization and health system strengthening. But this will be a matter of another conversation. At the heart of all this process, we have more accountability, greater trust, and more engagement of stakeholders.
Oh.
Back to the definition as the last slide, I will say it is what strategy purchasing is what WHO has defined, but we must add that it contributes in building more cohesive societies through learning, accountability, multi-level engagement, and trust building. Thank you very much.
Merci beaucoup Jean-Paul. On applaudit aussi, en tout cas ici à Genève. Je pense qu'on a une bonne transition. Moi, je parle français, ce n'est pas grave. Matt parlera anglais. Avec la présentation de Matt qui va justement montrer comment on peut exploiter les connaissances, l'évidence pour influencer les politiques de financement de la santé. Donc Matt, si tu peux partager ton écran. Donc je suis désolé, on doit continuer à aller vite dans le rythme. On espère qu'on aura du temps pour la discussion tout à la fin. J'espère que les organisateurs nous donneront un peu de temps puisqu'on a commencé en retard. Mais donc, nous allons maintenant avoir Matthew Jowett, donc coordinateur de Health Financing Unit ici à Genève, qui va vous présenter la matrice des progrès. Et j'ai demandé à Matt à faire un exercice. Je lui ai dit, tu ne présentes pas la matrice comme dans son contenu de financement de la santé, mais vraiment comme outil d'apprentissage politique. Comment ça peut aider les pays à naviguer la progression dans le financement de la santé. Matt, the floor is yours.
Thank you. And
I can keep it.
yeah, you can keep it. Hi, hello everybody. Pleased to be here. Matthew Jowett, working on the health finance in Geneva. I'm sure some of you, or probably some of you, have heard of the health financing progress matrix. As Bruno said, I'm not going to do a typical presentation that I tend to give on this. About how it's being applied in countries and where it's been applied. We can talk a little bit more of that. I want to give more emphasis on what this instrument is and why we developed it and how it's structured and what we think it offers. So let me dive in and I'll go pretty quickly through, then we can get some time for discussion. So why did we develop the health financing progress matrix? It actually was motivated, I think through around the years 2014, 15, 16, 17, over a number of years, this conversations about how we demonstrate the impacts of our work on technical assistance on health financing, strategy, policy strategy. What does health system strengthening mean? Everyone believes it's a good thing, but I think demonstrating impact is not easy. So it grew out of that conversation. I think we're always looking to improve our comparative analysis. Obviously, sitting in headquarters in Geneva, our job is to look across what's happening globally, and to harvest learnings from that. And in the policy space, we do that through a lot of written articles and so on. But I think we were looking for something that was a little bit more systematic for that. another sort of conversation thread was this idea of being able to track over time progress. And of course, we've got the health accounts, and we've got the SDGs financial protection data, but we all know about the time lags in there. And of course, those are quantitative indicators, and they don't capture the kind of dynamic of policy development and that sort of journey of how shifts are taking place, and are those shifts moving in a direction which generally we sort of deem to be positive, let's say. And I think, yeah, again, I think what the instrument also offers is to really sort of deepen our guidance, this sort of system-driven guidance, whole system perspective that we try and bring, which isn't always easy to do. And I think the matrix actually helps with that as well. So the value proposition, I mean, I'll just run quickly through some of the points, the key categories on the left there. Clearly, you know, the idea is that the assessments, because we basically apply this as a country assessment to generate intelligence specific to the country. But it needs to be objective, credible, and evidence-based. Well, that sounds obvious. But when you're talking about qualitative analysis, you know, you obviously have to work hard to ensure that objectivity dimension. And so that was a clear, the version 2 of the matrix after 3 years of testing, I think really beefed up that sort of quality assurance dimension. Provides clear country-specific recommendations on policy directions. So, yeah, I think, you know, the matrix, I'll give some more information in subsequent slides. It highlights areas of strength and weakness. And then within that, there's a lot of detailed information which is provided. Directions for policy, there's always this delicate balance between, in terms of giving TA and giving guidance. I'm not saying you should do X, Y, and Z. Rather, what we say is you need to move in the directions of X, Y, and Z. And it may be that in one country, that means a certain type of reform. In another country, it might mean a very different type of reform, but they're moving in the same direction. Thirdly, this idea of tracking change over time. So the assessment, I'll come to this again in subsequent slides, is very structured, and that sort of facilitates this, I think, the ability to highlight what's changed over time, or what's progressed over time, or maybe what's regressed over time. Getting closer to real-time information, the quantitative, you know, is, you know, the health accounts are T-2, financial protection data is often T-3, 4, 5. You know, if you're making policy now for the next number of years, you know, having old data is far from ideal. And so this type of qualitative information allows you to bring it right up to where we are now. So I think that closing that sort of time gap was important. Countries drive and own the assessment process themselves. I mean, we're not a funding agency. We don't come with our own timelines and structure and due diligence and demands. So the use of whether to do this assessment at all, and if so, when, is really driven by the country's own policy cycle and the timing around that. And we don't do fly in, fly out. Our model is we use local experts where possible, and we back up as part of that quality assurance process through our regions and other staff where we can. And at the end of all this, and what we're building now, is a knowledge platform where countries can quickly navigate a lot of very rich qualitative information, but can navigate across countries. Well, here's 20 countries. What are they doing on this very specific area of policy? So I think it offers that as well. I'm already failing on my timing, I think, Bruno. I'm going to put all these up on the slide at once. Complementing other assessments. Well, the World Bank has a really good health financing system assessment, very in-depth. It takes quite a long time to do, and I think quite a lot of resources to do it. Plus, it's only done, I think, where there's a project going on. So that will limit its availability. It's not particularly designed for monitoring, tracking purposes. Health accounts, well, I think most people know what those are. They're quantitative. And they tell you trends, you know, whether spending's going up or down or the mix of spending. But obviously, it's not about the policies to actually shift trends deemed negative, for example. The AU developed something, well, it's had the health financing scorecard for a while, and it now has the health financing tracker, which is, well, the scorecard's purely quantitative. The tracker brings in some qualitative monitoring now, but we work very closely actually with the AU. So these two instruments, I mean, the matrix goes into a lot more depth on that sort of qualitative assessment. And I won't repeat that last one. The matrix builds on our established functional framework. So I think the fact that that's, you know, in terms of the discussion and the learning and the analysis, I think having that framework, no one's saying it's perfect, but having that established and largely or quite widely used, the language and everything that comes with it was very helpful. And the matrix basically extends from and uses that framework for its structure. And I think that's very helpful. It removes a lot of potential, you know, startup time in terms of the conversation that one's actually having. The instrument itself, it's in stage 1 and stage 2. Stage 1, it starts with this landscaping of a country's health coverage arrangements. What are the different schemes and programs that make up the architecture of the health system? And that's really, you know, ensuring that we get that whole system perspective. We don't zoom straight into one scheme. We care about the whole system and how the different, not just the design, we do care about the design of an individual scheme, but I think just as much care about how those different schemes fit together or do not fit together. And that's the whole fragmentation question, which was referred to a lot earlier. So that we always sort of start with that. And then 33 questions spread across those sort of functional areas. What's also new, I think we've sort of built on a lot of global knowledge learning in developing the matrix. What we've defined, we call desirable attributes. This is our best attempt at present anyway to articulate what we believe a high-performing health financing system looks like. So that gives us the normative foundation for this assessment. And we also very clear on explicit linkages. So if you improve policy on pooling, benefit design, revenue raising, specifically, how will it impact on efficiency, equity, financial protection, and so on? So we map, I think, rather than just saying it matters, we try to map those linkages. It's clearly challenging and complex systems, and we do put those out there as hypotheses, but we believe for the conversation and the learning to let's say take that jump forward to be a bit more explicit is quite beneficial. Yeah, I'm going to move on pretty quickly. These are just this is a list of the attributes of high-performing health financing systems, but I'm going to move on from those. But basically what we do is when we apply the instrument in a country, we need to judge where a country is relative to these attributes. And we do that through the questions. So for each question, we developed what we call like a mini maturity model. And we have 4 levels of progress. So this is just an example. One of the questions here, I can't see my answer. What measures are in place to address problems arising from fragmented pools? And we have 2 pages of guidance. And then we articulate what is it, you know, so we do analysis in the country. And then we say, does that fit at emerging, progressing, established, and advanced? And I think this just gives some structure and sort of some layer of, of judgment. The scoring is always, you know, crude, but the richness lies underneath it. But it does help to sort of signal, I think, and move the conversation forward. And just a final point to make that we do, and this, I think this is a sort of a new frontier coming up now for our learning and our guidance as WHO. And that's the importance of combinations of policies. So the matrix does recognize that combinations of policies matter to move towards a particular desirable attribute. I think that's an area for a big area for how we get more specific on what are the combinations. So a classic one is, on strategic purchasing, in fact, that if you're going to have incentives for improved efficiency, quality, what have you, combining those, in fact, some preliminary evidence already shows that combining those with clear cost containment measures is really important. And if you have one of those without the other, your impact is going to be limited. So I think we're generating a lot of learning from what we're getting through the application of this assessment in countries. But we see very clearly sort of what the next steps will be on that learning process. I'll stop there.
Thanks a lot, Matt. So it's a really nice illustration, I think. Well, I'm maybe biased, but I think it's a nice illustration of how you can make tacit knowledge, what Joel said called epistemic knowledge, the expert knowledge, how you make it explicit in a document, but it's also in a process, actually. And this is where I would like to engage with Serge. Serge, you have been yourself involved in implementing the health financing progress matrix in Côte d'Ivoire. And actually, for the story, it was Joël Arthur who was the expert who came to do the assessment. So we are talking among within a close circle to some extent. But you are also now implementing the matrix in Mali and in Guinea. So Serge, could you maybe focus on the process, how the process of the implementation of the matrix contribute to learning, policy learning, at the level of the different stakeholders? And I will have to be very strict with the time, Serge, so you have not more than 10 minutes, so I may cut you at some stage. So try to be super effective. Thank you for your understanding.
OK. Merci beaucoup, Bruno. Donc, je vais aller très vite pour montrer un peu comment la matrice des progrès peut être utilisée dans un processus d'apprentissage de politique de financement de la santé. Vous savez que, juste à titre de rappel, il y a plusieurs pays sont dans une situation où leur stratégie de financement de la santé n'est plus à jour. Et donc, heureusement, on a cette opportunité d'un outil qui est la matrice des progrès en matière de financement de la santé, qui permet justement d'évaluer les systèmes de financement de la santé et de mesurer les progrès de ces systèmes de financement de la santé. Et donc, beaucoup de pays ont eu à utiliser cet outil. Je prends par exemple le cas de la Côte d'Ivoire où j'ai travaillé, mais aussi j'ai travaillé au Mali, j'ai travaillé en Guinée. C'est un long processus parce que quand vous prenez le moment où les réflexions commençaient en Guinée, pardon, en Côte d'Ivoire en février 2022 jusqu'à la production du rapport, à la validation du rapport, il y a eu quand même plus d'une année qui se sont écoulées avant qu'on ait un rapport qui soit validé. Mais quand vous regardez ce rapport, aussi bien la première étape que la deuxième étape, la première étape qui montre, comme Matt l'a dit, l'ampleur de la fragmentation dans les dispositifs de financement de la santé, vous vous rendez compte que partout, c'est pratiquement la même chose. Ça veut dire que aussi bien en Côte d'Ivoire, au Mali et en Guinée, on se rend compte effectivement que la fragmentation, elle est réelle. Mais il y a plusieurs synergies que la matrice, plusieurs synergies possibles que la matrice nous a permis de relever. Et la matrice nous a également aidé à faire des réflexions sur les possibles articulations et les complémentarités qui peuvent exister entre ces différents dispositifs de financement de la santé. Et il y a aussi des décisions politiques qui doivent être prises justement pour qu'on arrive à cette synergie, à cette articulation et à cette complémentarité. Donc ça, c'est déjà un premier point sur lequel la matrice nous pousse à la réflexion, nous pousse comme Joël l'a dit dans sa première présentation, nous pousse à de l'apprentissage autour de ces nombreux dispositifs de financement de la santé qui doivent travailler en synergie et en articulation. Dans la deuxième étape de la matrice, comme Matt l'a présenté, qui travaille justement où on traite de toutes ces questions en rapport avec les attributs souhaitables, il y a 7 attributs souhaitables avec 33 questions. On ne va pas entrer dans les détails de ces 33 questions, mais on se rend compte également que quand vous prenez le cas de la Côte d'Ivoire, les différents domaines ne sont pas au même pied d'égalité. Il y a d'autres domaines pour lesquels nous sommes à un niveau de progrès qui est émergent. À d'autres niveaux, nous sommes à un niveau en progression. D'autres domaines, nous sommes à un niveau établi. D'autres domaines, nous sommes à un niveau avancé. Je voudrais que vous puissiez retenir d'abord ce schéma parce que je vais maintenant y revenir tout à l'heure. Lorsque vous prenez également, vous analysez également les résultats de la matrice par rapport à l'étape 2 qui traite de ces différents domaines, mais ici particulièrement qui traite des aspects des buts et des objectifs en matière de CSU, mais vous vous rendez compte qu'effectivement que en termes de progrès, on gravite autour du niveau en progression. Donc, il y a encore beaucoup à faire pour le système de santé pour arriver au niveau établi et ensuite au niveau avancé. Donc, c'est pour vous montrer un peu comment la matrice peut nous donner des orientations, peut nous donner une situation à l'instant T des progrès en matière de financement de la santé. Et cette information, on peut ensuite l'utiliser pour de l'apprentissage et pour du dialogue autour du financement de la santé, comme je vais l'aborder tout de suite. Donc, la matrice des progrès, elle peut être exploitée aussi bien pour évaluer le financement de la santé, comme je l'ai vu à travers l'étape 1 et l'étape 2, mais elle permet aussi de servir d'assise pour des points d'action sur le financement de la santé. Je l'ai dit précédemment, la situation actuelle de ces 3 pays dans lesquels j'ai eu à travailler, la Guinée, la Côte d'Ivoire et le Mali, ces pays sont ils ont des stratégies nationales de financement de la santé qui doivent être révisées. En moyenne, leurs stratégies ont 5 voire 8 ans d'ancienneté et elles doivent être actualisées également. Et ces pays également, ils doivent actualiser leurs plans nationaux de développement sanitaire. Et donc, la présence de la matrice, c'est une opportunité pour mener ces évaluations et avoir des recommandations claires qui peuvent être ensuite utilisées pour actualiser les documents de politique nationale, actualiser leur stratégie nationale de financement, exploiter également pour actualiser leur PNDS, mais en plus, et on va s'attarder un peu sur ça, en plus, ça peut également aider à organiser des dialogues sur le financement de la santé, parce qu'on peut exploiter les données de la matrice, les données de l'évaluation qui est faite avec la matrice pour l'organisation des dialogues au niveau national sur le financement de la santé. Nous l'avons fait en Côte d'Ivoire. En Côte d'Ivoire, il y avait un atelier national sur le financement de la santé et la stratégique des soins de santé primaires, et on a utilisé l'évaluation, les résultats de l'évaluation de la matrice comme base de réflexion pour conduire tout le processus de cet atelier. Alors, comment on a procédé? Et peut-être que c'est un modèle que d'autres peuvent également suivre dans leur pays. Comment on a procédé? On a créé différentes sessions au cours de cet atelier, des sessions autour des principaux domaines de la matrice. Et vous savez qu'à l'intérieur des domaines, il y a toute une série de questions. Et on a pris pour chaque session qui correspond à des domaines de la matrice, on a identifié toutes les questions avec leur score. Donc, il fallait, au niveau de chaque session de notre atelier, associer la session avec toute une série de questions et les scores qui étaient obtenus par rapport à ces questions. Alors, pour chacune de ces questions, il fallait maintenant identifier des propositions d'action pour améliorer le score. Comme vous le voyez, par exemple, ici, il y avait des questions pour lesquelles le pays avait un score de 1, il y avait des questions pour lesquelles le pays avait un score de 2, de 3 et pratiquement pas de 4. Donc, il fallait donc identifier, comprendre d'abord pourquoi le pays a obtenu un score de 1 ou de 2 et pas 4, et identifier maintenant des propositions d'action qui permettraient au pays d'améliorer son score obtenu lors de l'évaluation. Alors, la matrice également peut nous aider comme démarche rigoureuse dans notre réflexion, parce que la matrice, c'est un document d'orientation qui, pour chacune de ces sessions qui correspondent à des domaines, la matrice peut nous donner le score, pour le score avancé, le score le plus élevé, la matrice donne des critères qui permettent d'atteindre ce score avancé. Et donc, c'est à nous maintenant de voir quels sont les critères qui permettent d'atteindre le score le plus avancé et qu'est-ce qu'on doit alors rechercher justement pour atteindre le score avancé tel que la matrice le préconise. Parce que la matrice vous dit, ben, pour avoir le score avancé, voici les tels critères que vous devez respecter. Et donc, si vous ne savez pas, vous n'avez pas ces critères, donc là, on peut maintenant, sur base de l'information fournie par la matrice, essayer de réfléchir sur la meilleure manière de rechercher le score supérieur. Et il peut arriver que lorsque vous êtes en train de rechercher ce score supérieur, que vous soyez peut-être obligé de savoir, mais pour l'atteinte de tel ou tel score peut nécessiter une décision politique, mais il faut le soulever. Et c'est avec cet exercice-là, vous arrivez donc à confronter cette force analytique de la matrice aux orientations qui peuvent émerger lors de discussions autour des discussions au cours de cet atelier. Et donc, c'est vraiment ces discussions-là, cet apprentissage autour de la matrice et de ses scores et de ses critères qui a constitué le dialogue qui s'est déroulé entre les techniciens et les acteurs du niveau politique lors de cet atelier que nous avons eu à organiser en Côte d'Ivoire. Et donc, vous comprenez très bien que la matrice des progrès peut être et on va s'arrêter ici, la matrice des progrès peut être un outil aussi bien être considéré comme un outil de diagnostic, parce que ça vous aide à comprendre le niveau de progrès du financement de la santé à travers son étape 1 et son étape 2. Mais la matrice des progrès peut également servir comme un outil d'apprentissage. Et ici, donc, on a vu qu'en tant qu'outil, cette matrice permet justement de poser le diagnostic des progrès et des faiblesses du financement de la santé, aussi bien pour le Mali, la Côte d'Ivoire que la Guinée, comme j'ai eu à le démontrer, notamment avec la fragmentation des financements de la santé. Mais la matrice peut servir également de catalyseur d'apprentissage politique, parce qu'au-delà du diagnostic, le processus d'évaluation lui-même a joué un rôle clé dans l'apprentissage en Côte d'Ivoire, avec la participation d'experts nationaux et des partenaires techniques et financiers dans cet atelier. Et au cours de cet atelier, au cours de ce processus d'apprentissage, il y a eu une appropriation accrue des résultats par toutes les parties prenantes qui étaient dans la salle. Il y a une meilleure sensibilisation sur les bonnes pratiques en matière de financement de la santé. Et il y a aussi une stimulation du dialogue entre les techniciens et les acteurs politiques, ce qui facilite justement l'adoption de recommandations éclairées. Et comme je l'ai également montré dans l'un des schémas, ben, cette matrice elle peut également être utilisée dans un processus de planification stratégique. Si on doit, par exemple,
Serge, il faut qu'on clôture. Excuse-moi. Donc, est-ce que tu peux vraiment terminer dans
cette
les 30
matrice elle
secondes
peut être utilisée, merci Bruno, cette matrice elle peut être utilisée effectivement si, en termes de planification stratégique, si on doit actualiser ces documents les différentes stratégies nationales de financement de la santé et les différents plans nationaux de développement sanitaire. Voici un peu en gros ce que je peux vous dire en ce qui concerne l'utilisation de la matrice de manière concrète dans les 3 pays que nous avons eu à utiliser et sa contribution dans le processus d'apprentissage. Merci beaucoup, Bruno, et merci à tous.
Merci Serge, désolé de t'avoir bousculé, mais on est vraiment en retard et donc je ne sais pas très bien comment on doit gérer ça. Donc je vais donner la parole à Joël. Je sais qu'il y a une session qui va commencer normalement dans 10 minutes. Je sais qu'il y a une session qui commence dans la même salle puisque je suis aussi un des intervenants. Ce sera avec ma collègue AfHEA et on va travailler, on va réfléchir sur les disconnects entre les paquets de bénéfices et les mécanismes de financement de la santé et la prestation de services. On va discuter de ça à partir notamment du cas du Rwanda, je pense, et peut-être. Et donc on veut vous garder avec nous parce que je pense que ce sera une très bonne session. Mais Joël, est-ce que tu peux nous dire quelle est la disponibilité de la salle et de l'audience? Je sais que vous avez un break, donc je sais aussi que les traducteurs doivent se reposer un peu. Donc voilà, qu'est-ce que vous décidez à Kigali?
Donc la question est posée, what do we decide to do? Can we take some questions, some quick questions? OK, je pense qu'on peut prendre peut-être 1 ou 2 questions rapidement.
Oui, vas-y, Joël. Si vous avez des questions, Et peut-être, comme Joël est dans la salle, vous pourrez l'attraper dans les prochains jours. Donc, est-ce que vous avez une question plus spécialement peut-être vers Matthew qui est à côté de moi? Est-ce qu'il y a des questions spécifiques sur la matrice des progrès? Euh,
We have specific questions regarding the health financing progress matrix. Or any other questions? Yes.
Thanks a lot. All super interesting. I'm Danielle from ODI Global and the Collaborative Africa Budget Reform Initiative. For Matthew, I wanted to know on the health financing progress matrix, I understand the scoring is not an exact science and it's a bit of a heuristic, but how are the scores set? Is it compared to sort of an idealized version of a high income context? Or is it like sort of benchmarked against a lower income or lower capacity context? We saw a presentation on Uganda's health financing progress matrix earlier, and some of the scores that you would expect in Uganda compared to its peers to be quite high, like use of output-based payments and looking at autonomy of facilities were really low, in program-based budgeting also were really low in Uganda. But compared to its peers, Uganda has done very well in those regards. So just wondering what that benchmarking is. And then for the other presenters, in terms of looking at the policy lessons, we know that documenting any sort of lessons during policy implementation is very difficult. People on the ground aren't necessarily tracking this. So I was wondering, was that process done retrospectively? Were those questions asked of stakeholders after the fact, or was that documented throughout the process? And were the research questions and the focus areas set out at the beginning? I'm just interested in how that process unfolded. Thanks.
okay, let's go for the question to Matt first. Yeah.
Yeah. Thanks for the question. Yeah. So we've designed the matrix to be applicable across all income level settings. So that was quite challenging, clearly, but that's certainly the objective. So I think this is the big area for improvement for us, how we articulate what is progressing, what is advanced, what is emerging for each of the 33 questions. I think that's a continual process of refinement. Maybe just quickly, I think consistency in scoring across countries is also something we need to get better on. I mean, this isn't a World Bank CPIA where they invest a lot in that because it actually drives a lot of money, how money's allocated. But we are conscious of that. So, yeah, and I think the way we've written happy to discuss further about this. I don't know if you have access to the guide itself and just see how we've managed to try and navigate that challenge. So thanks.
Maybe I can just compliment, because I was involved in the follow-up of the matrix in Sao Tome and Principe, a very small country with a very basic health system, but a kind of the vintage of the NHS model inherited from the colonial time from Portugal. And actually, on some questions, they have a very high score because actually they have not taken the kind of fashions and hypes that other countries took. So they have very little fragmentation, for instance.
Right.
So, but we agree that there are many issues with this health financing system and health system in general. But so, I mean, the matrix I think that even low-income countries can score very high on some dimensions.
Yeah.
But yes, so it's not a matter of being rich or poor.
Yeah, maybe just a final point. I think the other thing we sort of not struggle with, but we really need to do a little bit better on the next version of the matrix is, what we are measuring often is the quality of policy. But how well things are being implemented is, of course, a different question. And so finding the balance between those things. So I think Uganda has some very sophisticated policies in place, actually, but it still has major problems. So it raises lots of interesting issues as well.
Thank you. For your second question, I recommend you to grab Joël Arthur. He's around. He will be happy to share his research. This is his PhD research, actually. So Joël has a life before being General Secretary for Burkina Faso. So I'm sure he will be passionate about sharing his approach and methods. I think that I prefer not to cut your time. I think that everybody deserves a rest. I want also to secure enough time for the next session. So you are really welcome in the next session. It will be a review also of some cases and I think a very important discussions how to make better connection between benefit package and health financing. We know a few countries which have been struggling with this lack of connection. So please, thanks a lot for being with us. Thanks for Joel for being there. And thanks for the speakers from abroad. And then have a good break and see you, maybe some of you in a few minutes here in the room. Thank you.
I would love to say, but I won't. But maybe some of this stuff we should bring to one of.
Merci Joël.
Ok, bon après-midi.
Merci beaucoup.
Merci.
Okay. Serge, tu es là, Serge, tu m'entends? Est-ce que tu vois ma dia à l'écran?
Oui, je suis là, je la vois.
Attends, j'ai baissé le son, donc je t'entends pas très fort. Peux-tu parler fort?
Oui, je suis là, je vois très bien la dia.
Attends, je dois changer mon son.
Moi, je t'entends très bien.
Oui, attends, je dois... Voilà. Tu peux parler une fois encore? Je suis en
Je
train de monter.
t'entends très bien et puis je vois la diapositive.
Très bien, voilà, parfait. Ça va, je vais chercher un petit peu d'eau. So we have to check when Kingsley is in the room.
Hello, Bruno.
Yes, Kingsley.
Can you hear me?
Yes, yes.
Do you want to project, or you want us to project for you?
We can share the slides from here. It's maybe easier. So I have the slides on my. I understand that you can see mine, so then we can go.
Okay, then that's fine. All right. Good afternoon, colleagues. Can we start now?
For Geneva, we are ready. AfHEA is next to me, so we are available to intervene.
Good afternoon, colleagues. Welcome to the afternoon session. We are looking at designing accessible health benefits, contextualizing priority setting to country health financing and service delivery systems. So in this particular session, we are going to have 3 different presentations. The first one will be delivered by my colleague Bruno from WHO HQ. And Bruno will be looking at enablers and barriers to domestic financing for non-communicable diseases and mental health. What are the opportunities for benefit package design? This will be followed by a presentation on the WHO framework for robust institutionalized health benefit designing processes. And this will be delivered by my colleague, Alti from HQ. They are all going to be presenting virtually. They are already online. And then the third presentation will be delivered by Stella. Stella will be sharing Rwanda's recent journey towards institutionalization of health benefit package design processes and their ongoing work to reconcile priority setting analysis with broader efforts for realizing entitlement through paying providers and quality service delivery. At the end of the 3 presentations, we will hear from our colleague from Africa CDC, Josephine, who would pretty much reflect on the linkages between priority setting and health financing arrangements, and more especially what Africa CDC is doing in this particular space. So without wasting much time, we will get our first presentation running. And Bruno, over to you on the domestic barriers.
Thanks
Thank
a
you
lot,
very much.
Kingsley. Thanks everyone. I'm really sorry for not being in Kigali. There have been some restrictions with the new geopolitical situation, let's call it like that. But I'm very happy to present work that we did last year together with Leonor Batiema, who was the PI for the study in Ghana, and Sefonias Getachew, who was the PI for the work in Ethiopia. And let me see how I can move my slides. Yes, this was actually work to prepare an international dialogue co-organized by the World Bank and WHO, which took place in face-to-face in Washington in June last year. And so we agreed that to inform that dialogue, it was important to collect some primary data, do some case studies. And we decided that we thought that Ghana and Ethiopia were interesting questions to investigate these problems of barriers and enablers to domestic financing for MCDs and mental health, because these are 2 countries where the global health community has been investing for quite a while, both in terms of priority setting, health technology assessment, benefit package design, and so on, but also health financing arrangements. Well, I mentioned the global health community, but of course, primarily, these were investment by country themselves. We know that Ghana has been very an early mover with the national health insurance for its population and with a significant achievement. And we know also that Ethiopia is moving fast in terms of scaling up interventions and so on. So we did these case studies where, from a method perspective, it was mainly document review and structured key informant interviews. around more than 40 key informants in Ghana, more than 20 informants in Ethiopia. What the framework, and I think it's good to spend just some time here on the framework. Well, some of you may be familiar, that's quite a classical framework in health policy analysis, is Kingdom's framework, multiple stream framework. And this framework, if you look on the left, you have problem stream, policy stream, and political stream. And Kingdom's proposition is to say something happen in health policy or in policy when these three streams come together. The problem stream is the most important is that the society recognizes that a problem is an issue which requires policy action. So the recognition that something should be done. But on the policy stream, you have actors developing solutions and proposing solutions, and they have their solutions quite independently from problems, and they will try to link their solution to an existing problem. And then on the political stream, that's the politics. Obviously, it's politicians recognizing that by addressing the problem and using a specific solution, they will secure some support from their constituencies, for instance, for the next elections. When these three streams come together, you have what we call a policy window. And on the top of the framework, you have policy entrepreneurs. These are individuals, actors, organizations, which try really to bring the three streams together, and to often because they want to propose a solution, and then things move. Okay, so what we have done with in Ghana and Ethiopia, what we did was really first to check if there is no domestic financing for NCDs or mental health, or if there is too little financing from the government for that, there should be a problem somewhere on one of these streams. Is it a problem of non-recognition of the urgency to act? Is it because there is a lack of solutions? Is it because politicians are not paying attention, not interested? And we came out with the main conclusion that there is a problem on the problem stream. There is a lack of recognition in these societies that mental health and NCDs are huge problems requiring actions. Here, of course, I'm summarize very quickly the findings. We are producing papers on these findings, so you will find that later on. I would like to focus on the case of today. It's really this discussion between health financing arrangements, health technology assessments, and priority setting and service delivery. And these two countries have been exposed to multiple streams of solutions. And I want to be honest, if you just check with WHO, you will see that some of us are going to countries to help them with health financing arrangements, to do health financing reforms. Some of us are going to countries to help them with priority setting, to producing benefit package, for instance. And some of the colleagues are working on service delivery and also on service delivery models, implementations, but even also prioritization. So what I think that what the two countries miss, actually, this is a bit one of the findings, is there has been to some extent, a lack of someone playing the role, bringing these different streams of solution in something coherent. And instead of that, countries have received these supports, often from external, let's be clear, and with these actors coming from outside and say, look, I have a solution for your problem. And we lack this supra-policy entrepreneur, we call it like that, who would have combined these kind of things. Of course, you can tell me that's the job of senior technocrats in Ghana and Ethiopia, of course. But still, I think that it's also up to us, for instance, in Geneva, but in Washington, in Seattle, or elsewhere, it's also up to us to think, to recognize the reality of countries and say, look, we have to do our own work to coordinate our propositions. So to make my case, let me go to the next slide, where I will talk really about many health financing arrangements and priority settings. So you have, let's see kind of ideal types of situations. You have a country which has an NHS model with a public budget. There, in terms of priority setting, you could say, okay, I will produce an essential health service package, okay, which will be delivered by the public sector. People working on the health financing, they will say today, oh, you have to do PFM reforms, you have to do provider payment reforms, you have to, well, we have propositions, I mean, for countries like that, and we have been, I think, quite productive, actually. Then you have another set of countries where they have mainly a social health insurance, and which may be, for instance, open to private providers. And there you will say, well, you have to develop a health benefit package for the health insurance, for the insurees. They should know what they will get covered. And then in terms of health financing arrangements, you say, oh, okay, now you have a fee for service. You should move maybe to capitation, or you should introduce DRG for hospitals. You should accreditate private providers. So you see, for these two extreme cases, we have quite clear propositions, and I think they are quite coherent, and that's not where the problem is. I think the problem is in between. We have many countries which are actually transitioning from the left to the right, and they have a combination of situations. So they have the NHS, they have public budget, but they have also social health insurance. And on top of that, they have global health initiatives. So what does it mean? It means that in terms of priority setting, some people will propose them to do an essential health service package. Others will tell them you have to do a health benefit package for your health insurance. And on top of that, you have global health initiatives telling, oh, you do this and this for HIV, you do this for TB, and you don't have to do all these HTA, for instance. Okay, and then in terms of health financing, you can imagine also the nightmare, because you have to think all these different schemes. We know that there is, and this fragmentation of schemes is very, very present in many countries. On top of that, you may have schemes promoted by by external actors, for instance. So in terms of institutional arrangements, it's a great complexity. And I think that's exactly the problem. I think that this is where many countries are. Obviously, Ghana is there, but Ethiopia is moving also in this direction. And so we have to recognize that we, the global health community, maybe we are an extra source of hazards for these countries. And on top of the thing that we bring, you must recognize that there are, of course, and this is the most important, there are stakeholders at country level. There is a middle class which have rising expectations for more advanced therapies, technologies. There is right to health, but you may have also political instability, macroeconomic shocks, where, for instance, because of change of the main product of the country, the price, I mean, there is a macroeconomic shocks, and you cannot accomplish what you expected to do as a Ministry of Health. So I have a slide on Ghana. There is a slide on Ethiopia. You have Kingsley in the room, who knows well the two countries. But if you take, for instance, mental health in Ghana, there is a mental health authority. So there is a Mental Health Act, which guarantees free healthcare for mental health patients. And this was developed at a time where it was mainly the NHS model, which was prevailing in Ghana. But the problem that this commitment was incomplete, there was not a clear funding established, or there was a tax which was discussed, but it was really never really introduced. And so there was a problem of funding mechanism. Okay, but otherwise, if you check Ghana, the country is checking all the boxes. You have essential health service package list. There is a health technology assessment capacity. They have been working, the National Health Insurance also has strong capacities. They've been working on provider payment. So you feel that everything is there, and actually there is a problem for domestic financing for mental health. So the country, of course, recognized quickly the problem of the non-allocation of funding to the mental health problems. So now they are trying to go through another door. They try to go through the National Health Insurance, but this means that it should be integrated in the benefit package. It means also that those who are not covered by the National Insurance may not be covered. So, and it's interesting to see that you need to connect these things. And I think my assessment after this mission in Ghana, but also in Ethiopia, as a community of experts, and I really mean also the academic community, I think WHO, we should take our part of responsibility. We are working on that right now. This workshop, this webinar is this testimony of that we are working together on that. But it's not only us. I think as a global community, academic community, I think we have not been helping enough countries. Ethiopia, quite similar story. Very good HTA capacity process in Ethiopia with a list of interventions, more than 1,000 interventions. They have identified those which would be exempted, cost shared and cost recovery, with the expectation that exemption would come from the government and global health community initiatives. But Ethiopia is a complex country. It's a federal state, so getting the commitment from the central government is not enough. You need also each state to commit. And the truth is that you know also that let's say the political situation in Ethiopia has been problematic over the last years. So health was not a priority anymore for the central government. And so yes, you have to reorganize things. So but there is this process of, okay, should we do a benefit package for the community-based health insurance? But at the same time, the country is preparing a national health insurance for the formal sector. And you get a situation which is very, very confused, I think. So I don't want to be much longer because this presentation was to kick off this session. But my thinking is that I think we need for better coordination between solutions. So all of us proposing solutions to country, we must be much more humble and recognize that we have blind spots. And I think what we could call the policy entrepreneurs at global level, we have a responsibility and we are part of the problem. So the situation where everyone come with his solution, but is overlooking other critical issues is not acceptable. I think NCDs and mental health, they are challenging also in terms of domestic financing because there is quite specific critical questions beyond benefit package, beyond health financing. In terms of models of care, how much you empower primary care, for instance, is really crucial. In terms of digital systems, you have to organize the longitudinal follow-up of your patients in terms of specialized workforce and so on. So we need system thinking. And personally, I believe pilot projects are really key, but these pilot projects should really be to force us to put our solutions together in something very concrete, and then you may find a way to scale it up. And then last point is that it's nice to come, especially, I think, no, it's not nice. I think we come from outside and we come with solutions and we say that that's the problem, you should address that problem. The truth is that the problem should be recognized at country level by the society. So it's the Ethiopian society, we should say mental health is an issue in our society. And it's same in Ghana, NCDs are a problem in our society. And so it means that we have to create space for national policy entrepreneurs to get this recognized in their society. So I think that I'm a bit challenging actors like WHO. Instead of us promoting solution and sometimes instrumentalizing, allow me to use this word, national experts, I think it should be the other way around. It should be national experts leading the policy process, whatever their capacity, MOH staff, civil society, academics, and using us, international organizations and agencies and international academics as resources. So that's the proposition I'm making for this session, and I'm a bit challenging maybe some practices, but I think it's time to recognize that. I will stop here, Kingsley. Thank you.
Thank you very much, Bruno. I always liken this conversation to the field of medicine. We have specializations. So some are into pediatrics, others are into, so in the area of health economics, that's how we see it. But because you see people specializing in health financing, colleagues specializing in economic evaluations, colleagues specializing in health expenditure tracking, what is missing in the equation is really the interconnectivity. So this session is really to see how do we integrate that. I'm sure many of you have seen the WHO's framework for health financing, where we've defined the functions. Revenue, you pull them together, and then you have to buy services on behalf of the population, and you have to pay for the services, right? But in buying comes in the issue of the benefit package. So your designing of your benefits must pretty much fall within the continuum. And that's basically the discussion we are having here. So the next presentation is going to be Alti in trying to address the issue of the disconnection between the economic evaluations as well as the health financing. We are trying to develop a framework to institutionalize HTA or priority setting into the entire continuum. So the next presentation is going to look at the framework we are proposing. And I think we'll get the opportunity to provide reflections in terms of what you think about institutionalizing the prioritizations, priority setting within the entire health financing continuum. So, Alti, it's time for you to share with us the framework, and then after that, we'll hear from Rwanda. Thank you very much.
Thank you, Kingsley.
If you want to project from your end, we can do that for you as well.
I'm projecting from my end. I don't know if you can see it.
Not yet. Yes, we can see it now.
Okay, great. So, as Bruno said in his presentation, this work that has led to us thinking about the framework resulted from us realizing that we are doing country support in parallel, as you said, Kingsley, each focusing on our specific areas. And realizing that we need to come together. So initially we started thinking about this as an effort to align our internal work on priority setting and health financing and other planning areas as well. But we think that there could be a benefit to presenting this more widely, and we see this as an opportunity not to, as Bruno already said, be prescriptive, that we think we have found a solution and we want to present the solution to you, but we thought of this session as an opportunity to honestly present to you our preliminary thinking on this and get discussion going and get thoughts in this session also on whether we are going in the right direction with this and what people are seeing in countries and whether this makes sense. So with that said, let me explain a bit how we arrived at this. So there are existing frameworks out there that outline the steps of priority setting. I'm showing two here that are commonly used. On the left side, the JLN framework, which has a heavy focus on the governance aspects and the appraisal aspects, and then on the right side, the CGD framework, which is more on the operational steps. So when we first started thinking about how this process should look like, we realized that financing considerations are not highlighted specifically in existing frameworks, and we wanted to attempt to basically do that, to highlight how financing should come into the priority setting process. And this thinking is not new in the sense that if you look at the WHO Principles of Health Benefit Packages document, one of the 8 principles highlighted there is very much about linking health benefit packages to financing mechanisms, and things such as accurate projections of fiscal space are mentioned, but also establishing agreements and provider payment mechanisms, improving the efficiency of the commodity procurement process, promoting access through payment rates, and then also openly communicating decisions about entitlements and rights to beneficiaries. So why we wanted to focus on financing for health benefit package design? When we look at the literature also on this and from our own experiences as well, we see a disconnect between, as Bruno highlighted in the examples, what is available in terms of resources and the content of the health benefit packages, and that being the most common reason for packages remaining aspirational and not being implementable. And we know also that using health benefit packages to advocate for increased funding is rarely effective. But they should be used as an instrument that is essential to strategic purchasing. So what we don't see in many cases is that financing is considered at the onset. We see that financing is more, especially when the packages are not tied to insurance. We see that financing is considered at the end as an afterthought after the package has already been developed. It's being costed, and only at that stage it's being considered. So we want to make the case here that financing should be critically considered at the onset of the process. Bruno already mentioned the scenarios where there are multiple financing schemes, and we are seeing that a lot also through our work on benefit packages, that there is a need for alignment across multiple schemes, that in many cases there is prioritization happening in parallel between global health initiatives, benefit packages for insurance, and essential health service packages that are happening as separate exercises. So we are making the case that there should be links between the schemes, but also that the package should inform budgeting. And it should not be just a list, but it should inform conditions of access and understanding by both beneficiaries and purchasers. So, as I said, we wanted to outline our current thinking on this process, and it's preliminary thinking. It's not meant to be prescriptive. It's not also meant to be a process where we think that these exact steps need to be followed in this exact order. We recognize that countries may be at different stages. We also recognize that there are different scenarios. Bruno talked about the scenario of moving from the NHS model to something that's combined with social health insurance and global health initiatives. So this is the kind of scenario that we had in mind when we put this together. But there are other scenarios, obviously, and this may not work exactly in the same way that I'm highlighting here in different scenarios. But what we want to highlight is in each of these steps, which are iterative and not necessarily follow a linear process, we want to highlight what are the considerations that we think should be taken into account in terms of linking to financing. So I will start with the first part, which is on preparing. So this stage is about preparing for the package and conducting a situational analysis, as I mentioned earlier, thinking about the financing at the onset of the process. In many countries, the package is not starting from scratch. There is something already existing. So looking at what's already there in terms of entitlements, and also looking at any existing financing strategy, and looking at the fiscal space, also the available fiscal space, as well as any parallel prioritization processes, for example, for essential medicines, essential devices, etc., vaccines. And then second stage would be the planning stage, which is where the scope and granularity of benefits is determined, and the analytical methods and sort of topic selection or candidate interventions are considered. So this is where the criteria are chosen, and there is room here, obviously, for choosing the criteria that will make the link between the priority setting and the financing, looking at effectiveness, but also budget impact. Then the next stage is the prioritization. So this is the HTA, traditional HTA type of stage where the HTA is conducted on the individual interventions, with the assessment, appraisal, and decision. But also we think that the feasibility of the entire package would need to be looked at in terms of considering financing and reimbursement, and looking at different scenarios that would fit within the available resource envelope. Then the next stage is the management and implementation. And this is where the decisions are translated into actions. So in terms of financing, planning, and costing health system strengthening investments, capital investments, but also making those explicit links between the benefits and budget allocations, ensuring that the budget allocation are aligned to the benefits, and also the provider payment processes, and aligning with other lists, for example, the list of medicines, diagnostic supplies, as well as with the procurement practices and price negotiations. The next stage is about communicating. So what this refers to is communicating entitlements to the users and to the providers. So defining, as I said, not only the list, but also how the entitlements and the conditions of access for those to be understood by the beneficiaries and by the health service providers, with the objective being reducing uncertainty. And lastly, the last phase is on monitoring, revision, and sustainability. So this is about monitoring the spending and delivery against the intended entitlements to ensure financial sustainability and to mobilize resources. So monitoring expenditures against the entitlements to make sure they match the intent, but also continuously assessing the financial sustainability of the package, because many factors may affect whether that package remains affordable over time, including demographic, epidemiological, or economic changes. And then linking resource mobilization efforts and strategies to intended expansions. And establishing funds to manage crisis and ensure that financing can happen in the future as well. So all of these we think of in an institutionalization umbrella, which you see at the top, meaning institutionalization of an evidence-informed priority setting process, so that this is not a one-off benefit package design process, but that the process for setting these priorities and for reviewing them and revising them over time is institutionalized. And what we mean by institutionalized is looking at several elements, including the enabling environment, so the political demand, support, the governance arrangements, the legal framework, but also making sure that the skills and capacity are there, the data and quality are there to support this process. And then the processes are clear and standardized. And finally, that there is a review and evaluation over time. Like I said, this is a preliminary thinking in terms of the priority setting process and how it links to financing. But I think that the next presentation will also highlight some of the challenges that are faced in countries. And we would like to have a discussion afterwards, I think, to get also your thoughts on what was presented and how we can improve this thinking and inform it with your experiences in countries. Thank you very much.
Thank you very much, Alti. So we will now move to hear from Rwanda in terms of how they've tried to institutionalize the health benefit package within the system. And Stella will help us to do that. Right. So Stella is...
Thank you very much. Thank you for having me. Stella Matutina Umuhoza. I'm a health economist. Currently, I work for Minister of Health, and I'm based at Partners in Health, PIH. So I was part of the team that supported the government of Rwanda developing a benefit package for cancer. We are now into implementation. Can I have the slide, please? So government of Rwanda, in Rwanda we have three, I would say, we have three main health insurance. We have the CBHI covering the majority of the people in the formal sector in rural areas. And it has grown from 7% coverage to 90% coverage today. And the same scheme is collecting revenues from different sources. And currently the contribution of members stand at 38%. So it means that the scheme, to be able to function, has to get subsidies from different sources. Government is contributing, but other schemes existing in Rwanda, including formal civil servant scheme, private schemes, are contributing to the financial sustainability of the scheme. And in 2020, the government of Rwanda put more subsidies in the scheme to make it sustainable. To make it sustainable, that's what I was saying. We moved from 7% to 9%. It's amazing. And the scheme has been financially struggling since 2012. And the government of Rwanda decided to put in place some subsidies because there was a very increasing pressure to add more services on the CBHI scheme because it's covering many people and it's only covering service provided in the public sector, but there's some uncovered services, including cancer. So it is unfair because we, civil servants, we are benefiting private specialized services in the private sector. And with the increasing of life expectancy, there is no way government cannot refuse adding new services on the CBHI. So now the puzzle, how do we do it? Now the scheme is viable, the scheme is financially stable, but what services are we going to add first? The conclusion was to say that you have to add those services that are more likely to have best value for money, which are going to respond to the growing technology, and also ensure that there is a transparent process, there's accountability in the process of adding and removing new services on the scheme. On top of that, the government says, I'm going to give you criteria. I'm going to put in place a governance framework to make sure that everything is done in a very proper way. In 2021, the government approved a priority setting methodology. It approved the committee composed of 17 members, the chair, Minister of Health, the co-chair, Minister of Finance, and the secretary, RISSB, to make sure that everyone is represented. And again, the government upfront put in place 10 criteria. Those are the criteria I want you guys to follow as you select, as you add new services on the CBHI scheme. The reason you have to make sure that what you are putting has have value for money, but also is sustainable. Now, everyone says, wow, we need cancer. Cancer, why? As of today, CBHI is covering most of the diagnostic. It covers most of surgical procedures. It covers also some radiation. What is making it drugs? Imagine you diagnose, but you fail to treat. So it's unfair. Why other people are able to go through the cancer treatment journey? Okay, we said, okay, HCA is something very new to us. Let's start with the most prevalent 10 cancer. We went on, we evaluated, we assessed, we come with a recommendation to present to the minister. The minister say, what? Why 10 cancer? It's unfair. CBHI is covering 90%. It's unfair. I can't approve a recommendation for 10 cancer. Go back and look at our national cancer treatment guidelines. It has additional 67 cancer, which are not which were not considered in our pilot assessment. So we went back, we worked with the experts. Now we come up with a very comprehensive exercise, and now our appraisal focused on 49 cancers. So our benefit package that I'm going to present is a package that is covering 49 cancers. It means that at least a patient with a specific cancer will get something on CBHI package. The process is the selection, the criteria, you collect evidence, you conduct an appraisal. Our appraisal involves 2 layers, the expert, the oncologist, as well as the committee, because the government has already put a committee, and the final decision comes to the minister. This is the appraisal. We, as assessment team, composed of national expert, international expert, we collected evidence on 10 criteria, and then we bring the expert. This is what we have. Does it fit to our context? Is it feasible? And then after presenting to the expert, now we come up with preliminary recommendation that we present to the committee. And now the outcome was that we recommended an evidence-based package of services for cancer. We differentiated our recommendation based on a stage of cancer. We look at the impact, budget impact, but also we look at other health sector considerations. The focus of my presentation is to show you the status, how far we are in the implementation of benefit package recommendations. So we say that everyone should get basic minimum care from stage 1 to stage 4. Core services that are more likely to help a patient with curative intent if early detected, all of them should be covered. And our focus was on the most prevalent cancer. there is no enhanced package. You can't tell the government pay for transhumance, pay for very expensive chemo drugs. No, we didn't go there, but we try to be efficient. You try to be to customize what fit to our context. How far we are? Now we have an approved national cancer treatment guideline. We have standard protocols. We have also developed national cancer control plan. It was developed, but not yet approved. We are now trying to include additional indicators in ADHS2. We have a patient cancer registry, which is that need to be expanded. It's upcoming. But now government is planning to set up additional cancer centers because now services are becoming more available. We are going to detect early. We should be able to treat. Second recommendation was about integrating the cancer drug in central medicine list. Currently, we are done with the quantification, and all the drugs that were recommended are now in our essential medicine list. And we are going to initiate the supply chain. The supply chain, that's the elephant in the room. We don't produce cancer drugs in Rwanda. How we go about? We hope to continue engaging different stakeholders. Again, we conducted a revision of health service tariff for public and private sectors because most of the services were not on the tariff. And the tariff should be based on actual cost. And the tariff was now approved. The budget, we are not starting from the scratch. Based on the services provided, CBHR is paying 4.3 million every year because we diagnose, we provide, CBHI provides imaging, but we are not providing some expensive services. And the recommendation, we found that there is a gap of 6.1 million every year if we are to cover the services, we are to implement the package. So the recommendation says that more domestic funding is required for cancer care. And again, we conducted a fiscal space for health. And also we have a lot of consultation meeting with RSSB and the Ministry of Finance. And the process was led by RSSB and the ministry. Guess what? There is a win. On 17 January 2025, government approved the cabinet of ministers, approved the revision of cancer package, and new financing and additional resources were added to the CBHI. And now there is no way you cannot implement the benefit package because now the funds are available. And the decision is to start implementing by our next fiscal year, July 2025. The package recommendation was also to ensure financial protection and affordability of cancer. It is ongoing. Currently, we are reviewing our co-payment policy and structure for cancers and other cost-prohibitive services like currently we are providing kidney transplant, total knee replacement. All those will be considered. Should we keep at 10% or should it go below or should even be completely subsidized by the government? We have many scenarios on the table. We are discussing with the government and the ministry. Hopefully, we get more clarity in the near future before the implementation of cancer benefit package. We are also trying amplifying our prevention and promotive activities, and more focus is on breast, cervical, and colorectal cancers due to the growing burden of disease. And now also we are also focusing on palliative and survivorship because now it's more of a business of NGOs. Now government also is saying we have to invest in palliative care and also strengthen the role of tumor board so that the decision to treat is participatory and comprehensive. On institutionalization, we are making some steps. Now we have an approved legal framework. We have a governance board. We have a committee in place. We have the expert in place. We have a secretariat. Now RSSB has put in place a department responsible for benefit package design. The former CBHI manager is now transitioning to Dr. Ruris, I think many of you know him, is now transitioning to the head of HBP. And the capacity development is ongoing, an operationalization plan is ongoing, and a communication plan for beneficiaries and implementers is also ongoing. We have some challenges. we are struggling on our own. We don't know how do we move from policy to the decision to implementation. We are trying to use our own context understanding to do through the process. I'm happy what the previous presenter did, but we are trying to think about how can we move from government approval to the implementation. So I think it's all of us to think about how can we have an integrated plan together in M&E, because we don't know how to go about. I think we still is learning by doing. And again, we are doing also other intervention in the silos. RBC is training the providers. There are some assessments that are happening in the way new cancer centers will be set up. There is a quantification of cancer drugs with a lot of issues in the supply chain. There's a capitation model at PhD levels, but we are not really doing it in a very comprehensive way, but we are moving. And we still have some limited financial technical resources, because if you can count how many people with skills to do this type of work, but we are doing our partnership. Lesson learned: it's possible to do a full HTA in low-income countries. It's possible when you are having a meaningful and continuous engagement of all stakeholders, policymakers, experts, providers, everyone. And capacity development is very necessary from the very beginning. And if you are to put in place, if you are to institutionalize HTA, you need a structure which is well capacitated technically and financially. Finally, the context matters. There's a very strong political will it's a government-led initiative, and we need to be pragmatic. In the previous presentation, we say that there are some unwritten rules in the HBP. You can read, you move from A to Z, but it's not always the case. It's messy, but you have to be focused, you have to be open, so that, because throughout the process, there are opportunities and barriers, and you have to ensure that the political leaders are committed, and also the process remain transparent, so that you can show accountability in the process. Thank you very much for your kind attention.
Thank you very much. Thanks so much, Stella. We're excited to hear the Rwandan experience. And at this point, we will call on Josephine and Stella to the podium just to have our discussions. But before we do that, I think I need to, please, let's welcome them to the podium. No. Can do the second one, I'll sit here. All right, so I think I can give the opportunity to participants in-house for questions relative to all the three presentations before we move into the discussion with our two discussants. Anyone? So you pick. Any questions? Yes. There's one here.
Thank you very much. So my name is Michelle, and my first question goes to the first presenter. So I realized that when it comes to health financing for NCDs, especially when it comes to mental health, in Ghana, we've included it into our health benefits package. But there's a challenge here in terms of the implementation. When you look at it, even though it's part of, it was recently included, even hypertension and the rest are all included. But even though it's part of it, it depends on the level of care. So when you look at our health system, from the primary to secondary and to tertiary, I mean, when you go to the tertiary system, you're able to assess that. When you go to the secondary, but when you come to the primary, there's a challenge there. So systematically, when you go to the lowest level of the primary healthcare system, even though it's part of the benefit packages, if you step into any facility, you won't access that care. So something like hypertension. If you have hypertension and you go to a CHIPS in Ghana, you can't access that care, mainly because when you look at the essential package list, it's not part of, so yeah, the medication for hypertension is part of the essential medicine list. But when you find yourself in a CHIPS compound, it's not part of the medicines that can be dispersed there. So when you go there, they don't give you that care. So I was just making a comment that it's good we include these NCDs into the health benefit packages, but we should also try and see how it's actually effective on all the systems of care. Yeah, thank you.
Thank you very much. I think there's another hand at the back there. So Bruno, we'll give you the chance to reflect on that if you have any comments.
Yes, and in fact, it's my brother had already started what I wanted to mention. It's the same thing I've also observed, and particularly with mental health in Ghana. You know, the issue with the Mental Health Act 2022 was done around a time where we had only 3 psychiatric hospitals providing these services. So there were more of severe mental illness, which requires sometimes hospitalization, or you should be detained and then be treated with medication. And so I've observed that while we are trying to find a way to use HTA to improve the service gap within, the implementation gap with this policy that says that if you go to public health facilities for mental health services, it's free. And so adding these essential medications for the 4 mental health conditions on the health insurance is great. Like my brother said, it's only when it's available. And now that we have integrated mental health services in primary health care, it's only though it's still focused on the 3 psychiatric hospitals where you can benefit from this initiative, but not at that level. And I've also observed that, particularly with mental health, I think it's very much medicalized without looking at conditions like mild to moderate depression. That doesn't necessarily require medication or being hospitalized, essentially. And so I think we should move to where most HTA is looking at medications, adding some essential medications to the service benefit package and all, to non-medicalized services like psychological therapies, essential for mild to moderate depression, which is critical because when we prevent that, we will reduce the burden on even the health system having to provide medication for severe form of depression or anxiety. So that's the comment I wanted to add.
Thank you very much. I think there's another hand here.
Yeah, thank you very much for those presentations. I liked the Rwandan experience and the way you went about it. But can you comment, because these are very important decisions that are made, and there are a lot of people with vested interests, and there are also people with power. Was there any level of influence of powerful people in terms of determining what should be next in the benefit package? Because I also saw in my country at this time, there's also push for cancer treatments. And we all know it's mostly because of the age of our politicians. And not necessarily that it's the biggest emergency that we have. So I think I would like to understand and know, this was very scientific, but there's always that issue of why cancer now?
So just to clarify, this is Zimbabwe, right? Okay. All right. So I think I'll allow my speakers to reflect on some of the comments. Who wants to start? Stella, you want to speak to that?
Thank you very much. Okay, it's very hard to say that it was due to
political pressure or whatever. But in 2019, the government of Rwanda commissioned a CBHI sustainability study that come up with a long list of recommendations. One of the recommendations was to move from ad hoc process of adding services on the scheme. At that time, I would say that there was a lot of political pressure, because whether my mother has diabetes and CBHI is not covering diabetes, I will go in the ministry, in the RSSB, say, I want you to add this because we have people suffering from diabetes. And that caused the deficit of the scheme for more than 9 years, where the deficit was accumulated over time and the scheme was about to collapse. So now, the CBHI sustainability plan, I was part of the team that conducted that. We made different people to discuss what should be the services to be added. And then there was a session to prioritize what should come first based on the burden of disease, because we have defined the criteria upfront to say, why should we start with cancer? We are covering diagnosis, we are covering surgery, we are covering this. This is not covered, so there is a wasted system. Now you should cover cancer. Now the next assessment, which is now happening, is disability, assistive technologies. In the past, because of the war and the genocide, government was providing assistive devices for free. And some of the wheelchairs, they are very expensive. Some of the mobility-related devices are very expensive, can go up to $1,000. And for a normal citizen of Rwanda, it's not possible to have it. So now the next is disability-related devices. And we know that the next will be nutrition. We know the list where we are moving, what should be assessed next. So I think previously there was a lot of pressure to add services, add in ad hoc way, but now we have a list where the assessment should focus. Cancer, disability. Now we started with the mobility, because more than 8% of people with disability is mobility. The next phase will be hearing and visual. We are not going to dental because it's more aesthetic. So we know now where we are heading. Of course, pressure is always there, but when you have, we have a legal framework backing you up. When you have criteria backing you up, there is no way. And here, corruption and accountability is very strong. You can do it. Maybe next year will not be in your position because just one mistake. So we are very careful in the way we handle our situations. Thank you.
Thank you very much. So, colleagues on the line, do you want to make any reflections based on the comment from the participants? Otherwise, I'll just go to Africa CDC just to hear from them.
Well, okay, oh, sorry. Yes, here is Bruno. So no, I listened to carefully. Like I listened carefully to the different people in the room, Michel and his colleague from Ghana. Yes, exactly. This is what we have observed when we did the work. We visited 1 or 2 health centers. We talked to clinicians there in working on mental health, and it's terrible actually. The nurse explained us how she paid herself for the medicines for her patients because they are in stockouts. And then, so when this is the title of the session, is we have to align health financing, benefit priority setting, and service delivery. And if it's not aligned, there will be a binding constraint, and the binding constraint may be the medicines, there may be the human resources for health in the facilities, maybe the distance for the people to reach the facility level delivering the services. So we all agree that for mental health, Ghana should go beyond its 3 psychiatric hospitals, which are not located at the best place for the whole population. Anyway, so yes, you have to develop activities in the district hospitals, in the ships, and so on. And so I think, yes, the reflection, the problem is that we have been working in silos. We have been thinking these problems in silos, and human resources for health are planning the needs, and then the medicine people are working on their side and so on. So what we need, and I think that Rwanda is working in this direction, how do we make sure that we don't work in silo, but we work in a coherent way? I think that planning is useful for that and system thinking, but we have to be humble also and realistic. I want to reflect also on the point from the colleague of Zimbabwe. When I was in Ethiopia, I met oncologists there, and they explained me what they try to do to develop therapies for cancers in Ethiopia. And of course, I could argue, say, oh, you know, I'm a health economist. I don't think it's the most cost-effective interventions. You should maybe do something very different for your large population. But who am I to come as a foreigner and to say to Ethiopia, I should not develop your capacity for cancer? Let's be realistic. Countries need to build their capacities as well. So I think when we set priorities, of course, it's cost effectiveness is very important, and burden of disease and so on. But we have to recognize also that countries have to build their capacities. It takes time. You know, they talk about an oncologist who have been trained for how much time does it take to train an oncologist? 13 years, 15 years. And so they train someone in Ethiopia, and then they say, but now we moved. He's in Rwanda, actually. So you see, you have this brain drain, regional brain drain. So I think it's important to recognize that countries have to build these capacities. But what is important from the oncologist, it will be that he needs enough practice, he needs enough technology, he needs the medicines, he needs to feel, or she needs to feel useful for her population. So I want to be humble here. I think we like to rationalize things in a very coherent way, but I think the reality is not that easy. And yes, I don't mean that there is an easy solution. We have to be pragmatic. And of course, the more we organize this rationing, which happens anyway, the more we can make it fair, the better. And so, yes, I'm certainly looking forward for the developments in Rwanda. That's maybe a way for other countries. But let's recognize the height of the challenges. Over.
Thank you very much, Bruno. So at this point, you realize that WHO has been working closely with Africa CDC. And so within the context of this topic, we just wanted to hear from Africa CDC a reflection on the linkages between priority setting and health financing arrangements. So Josephine, you want to share something with us?
Thank you, Kingsley, and thanks for having me. I'm Josephine Gatua, Principal Health Economist at the Africa CDC Division for Health Economics and Financing. So as the previous speakers have alluded to, we sometimes have a benefits package in some of the countries, but it just remains as a benefits package because there's no funding for it, which means we think in the majority of the member states countries, we know there's a lot of working in silos within the health sector. So even within the priority setting space, a majority of the countries, those who are actually even thinking of health benefits package, they deal with it as two separate things. They do not see that you need to think of the two concurrently because they influence each other. So it's from that premise that we started thinking, WHO has been doing a lot over the years. Then what's the problem? And we started visiting the countries. And you get to see every country is unique in its own way, there are problems, but it's not that they're not doing, for the ones who are working, it's not that they don't have it. Like if you go to Ghana, as you saw Bruno was presenting, they really have very, very nice documents, but when it comes to the implementation, you start realizing that's all. But if someone from Ghana is to present to you, you'll actually think there's no problem until you now start digging in. So we started now to think we have to make it a whole systemic thing. We have to show that you cannot think of priority setting without bringing in health financing, simply because priority setting informs financing. Financing can also influence what services are feasible. We also have the scenario where the priority setting, where the financing has, the services have to be reevaluated based on the realities that are on the ground. So within that, then it means we cannot just talk of, let's first do priority setting, then we come. But even within that priority setting, we have various challenges. We have capacity, it may be lacking. So for example, in the case of Rwanda, you take a step back and ask, in terms of the HTA and all that, how much did it cost them? Because I believe you used a lot of external. So what was the cost of that external? If we add it to what package was brought, and if we come now to bring the cross learnings we're doing across countries for people to learn, then it means you cannot just come and hear Rwanda did this without questioning of doing it. That's one. So we started training with WHO, where we have the five regions: Central, East, Southern, Northern, and Western. We meet them to train them on health benefits package. So, and health benefits package and priority setting together. And what this means is when it comes to the selection of who is being brought to be trained, we make sure the finance is there, we make sure the Ministry of Health is there, and the people even in the planning division. And when they come, they are trained. When they get trained, we task them even with coming up with their country roadmaps so that they can have milestones we can link to. They come up with where is the problem. From those problems, we start customizing solutions. And this is done in conjunction with the WHO so that we cannot also replicate and we can achieve more. We also now went a step ahead and created the continental framework for evidence-informed priority setting. And why this was done is because you realize some countries do it, but they stall. Sometimes because of the policy cycle. Sometimes you might have a minister who is very enthusiastic. He understands, assuming you have a health economist minister who understands this, they will push it. In 2 years, they are replaced. We go back to square one. So the best thing we said it's we need to institutionalize. And if you saw what I think AfHEA presented, when you institutionalize it, you go through all the processes, you will think through all the sections that need to be in place. And then we will not have to be affected that much by the political aspect. So we launched the continental framework, which now the next step is to take it down to the countries so that we can help the countries adapt to their own settings. And this, we are not also doing it in isolation. We want to know what other partners are doing. For example, the NICE in the UK is currently now trying to do HTA for Nigeria. They reached out to us so that we cannot replicate. So if we choose, for example, Nigeria, how far will we go? Then we can learn from them so that we pick up that. Something else we're doing is helping countries learn from each other so that they can know, because it's through that you feel strengthened that, oh, Rwanda has done it, so we can actually do it. Another thing we're doing is to advocate, having high-level meetings. So we will bring the technicals, and we are also bringing in the ministers. So we get the ministers of finance, we get the ministers of health, we put them together. And then we start advocating so that when the technical people start talking that language, then there's some conversation taking place. We are also doing, for example, if we talk of efficiencies, we are having a small budget that we are thinking, how do you expand it? And now PHC takes the center stage. Pushing down services from the PHC to community health workers and saying community health workers are doing may not solve the problem we are trying to solve of access and trying to achieve the universal health coverage. So we've gone a step ahead and said, why don't we call all the 55 member states? Tell us, let us have a list of services that CHWs you believe should be. We came up with a list of 110 last year. So now we're in the step of doing cost effectiveness analysis for the countries, taking into account the different maturity stages for the CHWs. So what we're doing is we are trying to create the demand so that they know if we are to put diagnostics, if we are to put treatment, which ones should we put first? That's another way of helping policymakers also start thinking, oh, so we cannot just lump services and countries to start learning. So we deal with demand, we deal with supply, and it's a whole systemic thing. It's not just one solution. We have to think of it from a whole system, and that's what we're trying to do. Thank you.
Thank you very much for the CDC reflections on the linkages between priority setting and health financing arrangements. So I have a question for Stella. Based on the Rwanda experience, we just want to find out were there attempts to align the health benefit package to the budget allocations and provider payment mechanisms within the system.
Thank you very much. It's not easy to answer, but what I can say is that from the benefit package exercise, we know how much resources are required. We know what we need the first year, second year, and also in our projections, we were able to show if we treat more people, what additional resources will be required. At least we have visibility of additional resources for 5 years. And that projection was used to fund CBHI because CBHI has to do the reimbursement, 90%, and a patient has to reimburse 10%. And that's one side. So we are asking CBHI to revise its benefit package and also to pay. We are also asking the client to use the services and to pay. That's how the co-payment is coming. On the side of budgeting, we want to equip additional 2 centers, cancer centers. One is Sehashuka, here in Kigali is another center in Butare, in the southern province, to treat cancer patients. Now in their planning, we have just completed assessment need of what equipment required, what additional staff are required. That has to be reflected in our budget so that they can be ready to start providing the services. So what I would say that the benefit package is not only pushing for investment in the health sector, but also is pushing the planning and the budgeting in the facilities, especially tertiary hospitals. Because if you don't plan for it, it's not approved by the government, it will not happen. So it's even though we are not very comprehensive, but we are trying to make sure that the recommendations, the cabinet decisions are implemented, because when it is a cabinet decisions here in Rwanda and signed by the president or prime minister, it's another thing. There will be a team to monitor the pledges. There will be a team to monitor the implementation. So we take it seriously because it's no longer at the level of technicians, it's now at the presidential site. So basically, I would say that, yes, HBP in Rwanda influenced allocation, influenced analysis of physical space, because we have to think about where do we get more resources? Is it on airtime? Is it on telecommunication? Is it on gambling? We are trying to identify new sources. And at the same time, the sin taxes for alcohol was increased. The sin tax for tobacco was increased when this benefit package was approved. So it's not on budget, but also on planning. And we need to make sure how our technicians are prepared, because they don't know how many equipment do we need, how many machines we need. So now we have to ensure that, as I said in my presentation, consultation is very critical, engagement of stakeholders, clinicians, planners, budgetary officer, Minister of Finance is necessary to be able to move from decision to implementation. Thank you. I say murakoze.
Thank you very much. My final question is actually to Africa CDC. Given the work you are doing within the space of institutionalization, I know Stella highlighted some of the challenges with the entire process, but what do you see as a potential risk or challenges related to institutionalizations in member states? What are some of the red lights you've actually observed?
Thank you. So in reflection with this, we have a big problem on capacity. So we don't have enough health economists, for example, who are within the ministries. And because of the brain drain, you meet the health economists that you're thinking, oh, when you look for them, the next year we go, they've left. So even if we are training, sometimes we train, and when you're training, they are also leaving for greener pastures. So that's one. And also the type of curriculum. So we've now gone back, we were doing on the first day, the curriculum development, which will have things now like priority setting within them. And we were validating it on Monday. And it's from there that we will now start pushing it down to the countries so that they can have them, engaging with the countries also so that they can be able to take up the students who are leaving, whether through short courses, whether what, so that they can be taken into the system. So capacity is one of them. And the political will is always a hindrance, but it's something that we have to keep trying and we have to keep pushing. We should not give up on it because everything is political will. And getting at least a champion who can push for it. For example, Ghana. I think Ghana, either your health minister sits in the committee for the HTA. So there is a more incentive, high incentive to see that being. So identifying champions, because it is true that the political will is being won. But those two are the greatest challenges, without, of course, talking of the resources that will always be a constant.
Right. Thank you. Thank you very much. And I think before we end this session, I just want to give my own reflection. In Ghana, I think 2020, 2019, thereabout, we conducted a political economy analysis and basically to serve as guidance for the ministry as they go ahead with their technical policy direction. And coming out of this research work, we identified the issue of capacity building. So when we interviewed the folks within the Ministry of Finance, they said every year, Ministry of Health is coming to us, oh, increase our budget. For us as Ministry of Finance, we are interested in languages such as return on investment. And you come to us, oh, we want to do number of trainings, number of so. Ministry of Trade is coming to us showing tangible return on the investment. And so the missing link in all of this discussion is really about capacity building at the ministry. So those of you from Ghana, you know, School of Public Health has started a course, a health economics program. So based on this research work, we had to partner with Ministry of Health just to create a platform for colleagues working in the ministry and its agencies to take advantage of the Masters in Health Economics program, paying for their tuition, and at the same time using School of Public Health to provide advisory services. It's as a result of the, the reflections and recommendations coming out of this particular. So I think capacity building is really important. Another issue has to do with the fact that, and again, I'm using the Ghana example. If you look at the health workforce within the health sector, they're actually given, allocated to the agencies by the Public Service Commission, right? The organogram within Ministry of Health has been the same since independence. But every 5 years, we are changing our strategic plans, our health policies, and so on and so forth. So there's a total mismatch in terms of the skill set needed within the ministries. And so the issue of having health financing, health economics department within the ministries or the agencies to be able to bring together financial and public health data together to make sense, which this can be done through health economics and health financing capability. Is actually missing. So my point here is that in as much as we are going towards integration, making sure that we are using the continuum, right? Revenue, pooling, strategic purchasing, provider payment, in all of this, right? That priority setting comes in. And of course, you need to know how much is available before you design your, and so it is important for us to work towards strengthening our departments, strengthening the ministry, to have the capabilities to be able to put all of this together and make a business case justification to Ministry of Finance. On that note, I would like to take reflections from my colleagues online, final reflections, and then if there is any closing reflection from participants, more especially on the institutional framework, if any comment on that, we'd like to hear that before we close this session. Thank you very much, Bruno, all team.
Thank you, Kingsley. It's been a really interesting discussion. I think very interesting to hear the Rwanda experience and the country experiences of the participants in the room. I think, as Bruno said, we would like to continue to maybe work with country pilots and do more learning along the lines of what Bruno said earlier, being more humble. We don't have all the answers, but we think there's opportunity to work more from a systems perspective, bringing together not only the priority setting economics work and the financing work, but also working with our colleagues that are doing work on human resource planning and planning of health products and medicines to bring it all together. Looking forward to, I think, taking this work forward and staying in touch on this. Thank you.
Thank you very much. Bruno?
Yes, thank you. No, sorry, we have, yes, no, thanks a lot, Kingsley. Thanks to the panelists and to the audience. It was a rich sessions and helpful. I would like to share a last, maybe challenging reflection. It's that, to my mind, HTA has been developed as well, priority setting along cost effectiveness analysis criteria and so on, has been developed in countries very mature with the health systems. So, you know, the discussion is, we have capacity everywhere, covering well the country, if you take England, for instance, okay, and so it's just a matter, do we finance these new interventions proposed by this pharmaceutical company or this new technology? So in terms of the priority setting exercise, it's pretty simple, actually. You just do cost effectiveness analysis. It's very simple. It's not the case in Ethiopia, because you have to do that, but at the same time, you still have to prioritize some resources to build hospitals, to build health centers. Because even in existing health centers, you may miss the mental health nurse, you may miss the general practitioner, and so on. So it's a double exercise of priorities for these countries. And I think we have not acknowledged that enough as a challenge. We have been, because we are too much inspired by the good practice in very mature health financing system. And to some extent, if you allow me, it was really nice to hear from Rwanda, and Rwanda is still a path breaker, but it's a very small country with a high density population. So if you have a center in Butare and one in Kigali, you cover quite well your population in terms of geographical coverage. This model does not work in a country like Ethiopia, which is a huge country and a federal country, furthermore. So yes, maybe we have been developing methods and processes which work really well in some ideal settings, like in Europe, for instance. And we have to go back to the thinking and say, okay, what kind of model would work well for a country which is huge, with huge priorities, DRC and so on, with indeed some limited maybe technical capacities in terms of analysis and so on. But indeed, you don't do wrong when you say, as Josephine said, you go to PHC, you are not wrong. You know that you will covering the need of many. But it doesn't mean either that these countries cannot develop the capacities for cancer, for instance. So we have a balance to strike, and I think we have still to do some work in terms of methods. Thanks a lot, Kingsley.
Thank you very much, Bruno. And at this point, we'd like to say a big thank you to Stella Matutina of the Rwanda Partners in Health. He's a technical advisor and a health economist, and he's been instrumental in the recent design of the Universal Health Benefit Package. Stella, thank you very much. And a big thank you to my friend Josephine Gaki Gatua. I hope I got it right. Africa CDC, for sharing your experience on institutionalization and the linkages. Right, and a big thank you to all of you for spending your time with us. We thank you so much for coming, and I'm sure this is just the beginning of the discussion around institutionalization of priority setting and linking that to the entire health financing arrangements. We are grateful. Thank you.